It is 2 p.m. Eastern, just trying to draw folks back. I know we had about a 20-minute break, but thank you very much for accommodating that as well. So make sure we get folks back up on screen and getting into our next measure. While we're doing that, I just want to check in with our next developer, who will be the developer for the last two measures today, which are 2967, which is the first one that will be up, and then followed by 3453, which will be our last one today. But Colleen, I see you're on. Great. Are we waiting on anyone else from your team? No. Okay. Thank you. I see Kristen's back. Thanks, Kristen. Paul. Stefan comes back here as well. Again, if recommendation group members may have left the call just for that 20 minutes, but are coming back through the public link, you may be on the attendee side, so please raise your hand. We'll promote you back to being panelist as well. So I know we had a couple of those maybe on that side. And Paul Tatum, you're back. Great. And Morris is back. And Morris, you have your hand raised. Not sure if you have an immediate question. Nope. Okay.
No, just was rushing back at 20 minutes.
Yeah, thank you.
Yep.
Okay. All right. Okay. Again, if you're coming back here, you can put your video on, just making sure everybody's here. All right. Okay. Great. So let's get started. So thank you all very much for accommodating that break. We do want to make sure we leave some space for our next measure, which is 2967. And as you saw via email, we are approaching these types of measures very differently here at Battelle. And there are various different types of CAHPS-like measures. So these are these patient experience survey types of measures, or at least measures that are derived from a survey instrument, the CAHPS survey, that are aggregated to a single score. And then there are definitely submitted for endorsement, but a numerous amount of these measures are submitted for endorsement under one CBE-ID. So we have implemented a policy here at Battelle that we definitely do not endorse the instrument. So as we get into these instrument-based discussions, the CAHPS measure is an instrument. Battelle does not endorse any instruments or surveys. Rather, we're endorsing the measure that's derived from the instrument that's aggregated to some sort of accountable entity. And we are reviewing those based on the criteria that we have or the rubric that we have in place. And with these CAHPS-like measures, especially the one we have today, there are 19 of these under this one CBE-ID. There are definitely some cross-cutting issues and cross-cutting topics that we want to present, but there are some nuanced differences across some of the measures, largely coming through the testing. And so we want to be able to evaluate the differences across those, and then we will be voting on each one of those measures separately. I will kindly ask the committee that if there are any concerns you have related to the measure that's questioning your endorsement of that, your continued endorsement of that measure, that's what we want to start to hear through these discussions. So how we will do this today is that we will first introduce the measure. We'll allow the developer to provide a 3 to 5 minute overview of that measure. We'll then go to the discussion slides. We'll quickly highlight those topics on both of those, drawing attention to some of the cross-cutting issues, which is really on the first slide, and then some of the non-cross-cutting issues, really more nuanced with the individual measures, which will be on the second. So summarizing all of that, we'll then flip back to the cross-cutting issues and just have the committee sort of discuss those. We'll start with our patient partner input, and then committee discuss some of those cross-cutting items before we go to the nuanced items or topics that came through largely with some of the testing. We'll refer to some of the testing attachments as well that were provided, just so that the committee can see some of the results there that raise some of the questions, both from the committee, but also through our staff assessments. And what we'll do is we'll start from with the measures by domain. So the scale measures are the first, right? So there's 7 measures there. We'll first draw attention to the nuance between those scale measures, which in this case, it would be just one measure that kind of came to attention from the testing. We will also ask you, after we display those testing results, if there are other measures in that 7 under the scale measure domain that really drew concern for you or you have major questions about that would cause you to change your endorsement decision on the measure. If there are no measures on there that really cause any major concern for you, we will assume that no issues were with that measure, and when we go to a vote, that measure will continue with endorsement. So please, to keep our comments concise and focused as we go through this, think about, does this really cause question for you on endorsement of the measure? Again, we will draw attention to the differences in those measures by domain with some of the testing attachments, but that's how we'll proceed today. We'll then vote on the measures within those domain, one at a time, and then we'll go to the next domain and repeat the process again. So we'll draw attention to some of the testing differences that we've identified. We'll then open it up to the committee to see, do you have any major concerns or questions beyond this, or would like to have additional questions related to your comfortability with continued endorsement. After the discussions end, we'll then circle back to vote, and we'll go through the measures in that domain and vote, and then cease that and go to the next domain and repeat the process again. Okay. I will also state that moving forward, we will be looking to how we can evaluate these measures, not as a bulk like this, because I know 19 measures is both a lot for the committee to consider as well as for the developers to submit. So we are working to build out our systems internally here to accommodate being able for the developer to submit these measures separately instead of 19 all together at once. This was something that the prior CDE evaluated these based on this one CDE ID, which made it challenging and difficult at times. And so we were trying to enhance that ability for these types of measures. So it's less burdensome to developers, less burdensome for reviewers as well moving forward. But our systems are not built out just yet. So this is how we're going to proceed for this measure today. All right, before we go any further and go through and introduce the next measure, does any committee member have any questions on how we will proceed or anything you want to revisit on that approach? Okay, all right, not hearing any, let's go ahead and get started. So let's go to the slide, thank you. So 2967, this is the Home and Community-Based Services Consumer Assessment of Healthcare Providers and Systems measure, or CAPS measure. The measure derives from a cross-ability survey to elicit feedback from adult Medicaid beneficiaries receiving home and community-based services about the quality of the long-term services and supports they receive in the community and delivered to them under the auspices of the state Medicaid HCBS program. The unit of analysis is the Medicaid HCBS program, and an accountable entity is the operating entity responsible for managing and overseeing a specific HCBS program within a given state. The developer here is the Lewin Group, and the steward is the Center for Medicare and Medicaid, or Centers for Medicare and Medicaid Services. It is a maintenance measure. Fall 2016 was last reviewed, and it's used for quality improvement within the organizations. And it is a patient-reported outcome performance measure. Since this is a patient experience measure, the inputs that are received from the survey are derived directly from the patient. So it's a patient-reported outcome performance measure. You can see the target population there, 18 years and older, who are in those long-term services and support, specifically in the home and community-based services type of setting. And the level of analysis here is at the health plan and both population and geographic area or state. Okay. So, Colleen, I'll turn it over to you for any additional overview within 3 to 5 minutes. Thank you.
Great. Thank you so much, Matt, and good afternoon, everyone. So my name is Colleen McKernan. I appreciate the opportunity to speak with you all today about HCBS CAPS. That's how we'll refer to it since the name's rather long. I'm a managing director at the Lewin Group. I'm joined by staff from Lewin and also our colleagues at CMS. Medicaid HCBS provides participants with disabilities the opportunity to remain in their communities. The types of disabilities covered include physical, intellectual and developmental, cognitive, brain injuries, and those resulting from diagnoses of mental health or substance use disorders. Examples of the services provided include personal care, so that's assistance with activities of daily living like eating, bathing, or dressing, skilled nursing, therapy, case management, supported employment, transportation, habilitation, defined as assisting participants in acquiring, retaining, and improving self-help, socialization, and adaptation skills, and also respite for participants' unpaid caregivers. The need for services can range from intermittent to around the clock. States have many options for the implementation of HCBS. The populations to include, the services that they should offer, and the Medicaid authorities that they use. So for example, delivery through a managed care or fee-for-service system, the ability to limit the number of participants or the geographic coverage within a state, allowance of self-direction where the participants can hire their own workers and manage a budget, and other things. Earlier this year, CMS finalized the Ensuring Access to Medicaid Services Rule. You might hear us refer to it as the Access Rule, which includes important new provisions to promote public transparency related to the administration of Medicaid-covered HCBS through public reporting of quality, performance, and compliance measures. The HCBS CAP survey provided CMS the first opportunity to measure HCBS participants' experience when they receive long-term services and supports, otherwise known as LTSS. Designed to facilitate comparisons across the hundreds of state Medicaid HCBS programs throughout the country that target different adults with disabilities, these programs can use this survey as part of quality assurance and improvement activities, as well as for public reporting. The HCBS CAP survey, a questionnaire with a maximum of 69 core items developed for measuring participant experience with the Medicaid HCBS and supports delivered by providers, covers topics such as getting needed services, communication with providers, case managers, choice of services, medical transportation, and personal safety, as well as community inclusion and empowerment. The survey also includes 3 cognitive screening questions, 9 questions to identify the relevant home and community-based services to be discussed while completing the survey, and 15 demographic questions. Optionally, states can also use a separate 21-item supplement that evaluates experience with employment services. CMS developed the HCBS CAP survey through the Testing, Experience, and Functional Tools demonstration, originally called the Experience of Care survey, where 8 grantee states piloted, tested, and modified the initial survey, which was then trademarked under the HCBS CAPS acronym in June of 2016. The National Quality Forum, the consensus-based entity at the time, endorsed 19 measures derived from the HCBS CAP survey in November of 2016. Following that demonstration, 15 states have fielded HCBS CAPS, either at the fee-for-service level or through managed LTSS programs. So on behalf of CMS, we performed a series of quantitative and qualitative efforts to assess the CBE 2967 evidence base, distribution of performance, scientific acceptability, feasibility, and usability. And so we look forward to the questions that you might have. Thank you.
Great. Thank you so much, Colleen, and thank you for your team. As everyone can appreciate, it takes a lot to look at these types of HCBS measures and do updated testing and collecting all of those data. So thank you very much, Colleen, to you and your team for all this work. Okay, let's go to the next slide if we can for our discussion point. So here is our cross-cutting items. Like I mentioned, I'll summarize this and then we'll go to the next and summarize those and circle back here. So there was some discussion definitely from our advisor group members, as well as some coming from our recommendation group around the feasibility of the instrument and improving the overall response rates, and thinking about whether there's an opportunity to reduce the survey size and creating different vehicles of distribution, as well as thinking about electronic capture of some of these data elements, right? So the developer did provide a decent response that you see listed here, a very sufficient response to the advisor group as well, recognizing that there is a breadth of technical assistance options for states, and they recognize that the survey is long, and it includes 4 different provider types, as we've stated, and only questions about the relevant provider types are really asked. The developer did not feel like a web or email version were appropriate in their population. They also have expanded into video conferencing, as well as data collected through via video, telephone, or in person to really help with some of the burden potentially with just in person alone. And I mentioned the technical assistance options, thinking about how that can support states or managed care plans. And as part of this effort, there's best practices to really improve the response rates are actually provided to those entities as well. They're also gathering inputs from states, as on users and what their recommendations are to actually improve on feasibility or response rates. And they anticipate having more information to present at the next cycle. And so in addition to that, some of these response rates, some of the comments we saw from a recommendation group, that these are somewhat similar in what they expected across all CAPS-like measures. So it's not something that's just unique to this one. These types of response rates are similar across various different CAPS measures as well, just to keep in mind for framing. Another topic here is the proxy data. So the proxy data is a comment from our advisor group are old that were used here, and the developer did acknowledge that, and they said that the proxy analysis that was done with the measure was originally created and tested, and they have not done a feasibility assessment since then. But currently, as you see, the rates of proxy responses are low, and likely represent those populations in which proxies are both necessary and appropriate. And some other explanation there around technical assistance, like we mentioned before. Lastly, with the cross-cutting piece here, this is bundling. So why personal assistance and behavioral health are really combined within here, and this is also coming from our advisory group feedback. And the developer did note that CMS is considering the feasibility of gathering data separately for personal care assistants and behavioral health staff. It would require appear in the next version that was to be the case, but would feed into the HCBS CAPS measures in future endorsement review. So going to the next slide, we start to get into a little bit more of the nuance here with the testing and drawing attention, and then we'll go into these a little bit more detail after we get through these cross-cutting items. Is there is reliability testing. There are 4 of the 19 measures that were provided that had reliability below 0.6 for a good portion of the accountable entities, ranging anywhere from like 50% to ultimately like 70% of the entities having that less than 0.6 accepted value. So we'll draw attention to those there. And then for validity, there was some validity testing done on some measures, maybe not all the measures. And so just getting a sense of some of the rationale for certain validity testing versus not, as well as some of the risk adjustment being for some measures, but not all measures. And we'll get into some discussion there related to maybe why that was the case as well. There are some also analyses done with validity, some correlation analyses. Some of the correlations were low to moderate, and so there were some questions there related to why that was the case, the rationale for maybe why something was low versus something moderate. Again, we'll draw attention to that with the PDFs from the measure submission when we get into those discussions. Now, lastly, use and usability could potentially be a cross-cutting item here. So this is performance on most measures did improve from 2022 to 2023, but it didn't include all of the measures. And it really is just that one data point there. There was about 6 measures that were not included in this performance analysis. And maybe we can see what the developer wants to add there. There's other elements with use and usability as well to consider here, a feedback mechanism in place, which there definitely is a feedback mechanism where the estates or plans can reach out to and ask questions for clarification. We talked about the technical assistance, and we actually want to see it's being used, in which we do see that there is a current or planned use for this measure. The usability component here also includes this progress over time. And really, there's this one data point from 2022 to 2023, but only for 6 of the measures were not included in that analysis, and maybe we can see why that was the case. So let me go back to the first slide here on some of these cross-cutting items. Let me first open it up to our patient partners. Thinking about this survey itself and the description of the survey, any thoughts on the meaningfulness of this to evaluate these services within home and community-based care, the experiences that patients might get? Your thoughts, lived experiences, or others that you'd like to share. So Carrie or Stefan or Cher, I'll open up to you. Your thoughts on importance to the patient community.
Well, I guess that's me to start.
Thanks, Stefan.
So I just have very general comments due to some personal circumstances. I haven't been able to go through this in as much detail as I want. First of all, I have some degree of understanding about surveys and response rates and so forth. And 7.4% if it's comparable to other surveys that are put out under CAPS, that seems like it's a success to me, or at least within the tolerance level. I think that surveys in general, there has to be a motivation to complete it. And certainly home health care provides some motivation for people to respond more than they would just for a consumer survey. The second data point that I noticed is that the recommendations for separating mental health versus physical health in the surveys are really appropriate. I think people without mental health issues might be a little bit put off by being included in that data set. So I think that's a very worthwhile recommendation. And on the surface, that's really all I have to contribute. I will probably comment more later.
Thank you, Stefan. Thank you for that. Appreciate it. So hearing about some of the response rates, and I can definitely see what other committee members may have to say about that and this separation of these two elements for personal assistance behavioral health, recognizing it's a good recommendation for consider. Chair, I see your hand is raised. Please go right ahead.
Yes, one thing that I've observed and I've heard from other patients with the Renal Support Network and patients that I know outside of RSN is that patients in particular were burned out on surveys, and I don't know how to incentivize people to fill them out unless there's some kind of a freebie attached to it, or they don't get some kind of coverage if it's not completed. I know that I have a prescription that's delivered that, if I don't sign off on it and respond with it, then it might not be covered by my insurance. So then there is a penalty if you don't respond. I don't agree with that way. As far as providers filling out surveys, I'm a dental hygienist, and we feel the same. So it almost seems like it's a no-win kind of situation, but that's just my input.
Thank you, Cher. Great input as well around burden to patients. Definitely calling attention to some of the response rate considerations. Are there different modes of completion or shortening the survey in any way, recognizing the burden to patients. So thank you for that. And thank you for drawing attention to some of the other considerations with penalties if it's not being captured. We will thank you for sharing that. Others, Carrie or other patient partners, any thoughts maybe before we kind of get into some discussions? Okay. All right. Maybe, thank you, Carrie, no additional thoughts. So maybe I can circle back with this first piece around the response, the piece around response rates and improving and this feasibility element, because I think Cher and Stefan, you definitely were touching on that as well. Those that have experience with these types of instruments as well, and I think, Morris and Margarita and others, Carol, you've been working in the home and healthcare setting. Are these response rates based on your experience something that is a concern? Is it something that we see consistently with other types of surveys? And any thoughts you might want to share? I'll start with Morris and then Margarita.
Sure. So first off, I applaud Lewin and Colleen thinking of ways to improve the response rates. I'll be honest, when I looked at these numbers, I thought they were low, but not out of the bounds low. And I even mentioned that in my comments that home health, hospital, all the CAPS measures have something in the 20 to 30 range. And so, even if some of these initiatives are taken, I don't expect the needle to move a whole heck of a lot. And so that's largely a decision between CMS and the CAPS contractors and what can be done. I think what matters most for this measure are these 19 measures is how the response rate affects the scientific acceptability of the measure. And I think we can know that very easily by looking at the reliability statistics for the measures for which it's reported. And by and large, most of these measures are not adversely affected by the low response rate. Reliability is largely a function of sample size, and it seems like you have enough sample size to adequately distinguish quality of the HCBS health plans. The second concern, which is a much more difficult concern to get at, would be on the validity side. You can imagine a scenario where, let's say, making it very hypothetical, very extreme here, but let's say you surveyed 100 people and all 22 people came from, or all of them were white, all of them represented a particular demographic. Then what you'd be getting is a measure that measures something different than what you're potentially saying that you're measuring. Sort of the general population quality of the health plan, you're maybe measuring a very specific subset, just that demographic that's very inclined to doing surveys. There are ways to get around that mathematically with weights if you have the right data. I don't know, honestly, if CAPS has that data. And in general, it's more to make the survey look either nationally representative or something along those lines. So those are my concerns. I don't know if there's a solution. I just want to raise it and have a discussion.
Yeah, thanks, Morris. Definitely we'll pull in. Oh, got some background noise there. Thank you for that, Morris. So drawing attention to maybe not the rates themselves are not strikingly any major kind of here for you. It's something that even with some of the things that we could implement, you would notice it may not move the needle much on the response rates. You really see that with the reliability, and we'll get into some of those differences. You drew attention to something that also Cher alluded to, which is maybe some of this incentive to actually complete the survey. Is that biasing the potential population getting to validity? Margarita, I don't know if you have anything to add to Morris or something new. I definitely will go to the developer to see if they have any thoughts, but go right ahead.
Just experientially, this is poorly understood by the patients, and in hospice, it's even less well understood because the survivor gets the CAPS survey, and there's conflating some of the issues that have risen and have been discussed in other venues. Is first of all, there is a low return rate, and CMS is looking to reduce the number. Is looking now to reduce the number of questions. The other thing that was interesting is just recently, CMS has now put out an approved informational brochure that home health agencies should be giving to the patient that actually tells them to anticipate this CAPS survey. And just the very, very preliminary results say it may be improving the rate of return. But if you look at the survey, if you look at the length of the survey and the questions of the survey, it's daunting, and people often, especially in like hospice or where there's multiple providers coming in and out, they conflate the different providers. So they don't have a good experience with their home medical equipment company, and the home health agency gets the brunt of the complaint. It's those kinds of issues. So I understand, and to me, none of the key discussion points really surprised me.
Thank you. Thank you so much for that, Margarita. Very helpful. So also drawing attention to maybe some considerations with validity here around conflating providers. You mentioned, there's some this anticipation notification from CMS that may be actually improving some of the response rates. So that's helpful to hear. But also hearing some validity potential concerns here, again, coming back to what Cher was maybe mentioning around incentives to complete. Carol, I'll go to you. Any additional thoughts on some of these comments or anything new to add here?
Yeah, I think Margarita's comment about conflating providers is important, but the other is just, I think of Morris's comment with the low response rate. I work with a population that probably 90% receive some kind of home and community-based services, and they don't open their mail. Their aide opens their mail for them, and that's the person providing care. If they have to be contacted directly, that becomes a challenge. I've been in people's houses where they get 50 spam calls in an hour, and so they don't answer their phone. So I think there are all kinds of barriers to getting a response, particularly when you're talking about the population that gets home and community-based services. And so even if they know it's coming and they know it's important, there are all kinds of barriers to them receiving it, to them actually personally either, receiving it or, being personally contacted. And the other is particularly folks who are getting like personal care assistance or have some kind of attendant in the home. That person becomes sort of a trusted confidant. And I've seen patients who will hand over documents they get to that person to complete for them and would have no idea that it's about evaluating the services that that person is providing to them.
Yeah, thanks, Carol. So drawing attention to maybe even proxy types of use, but maybe not even counting who that proxy could be as a potential area for bias. I'm hearing a lot about how the patient is or how the individual is completing this, maybe conflating providers. They're concerned about who is completing this. Are they incentivized to do it, or is there somebody else doing it and maybe that's just not being identified? Do others have any thoughts on this, or maybe any other recommendations potentially that could improve the response rates besides what we've been hearing already about reducing the survey size, providing other modes of delivery, anything for the developer or CMS to consider? Sarah, go ahead.
Thank you. I'd just like the developer to address their comment that related to use of video or, email or web-based surveys and why this population may not benefit from that.
Thank you. Thank you for that. Okay. And Paul?
Well, thanks. This is rich and complex. Curious about validity from a more qualitative perspective and hearing the voice of the people. Without digging into the development of this tool, was curious about that whole person-centered, the Corey people talking about nothing for us without us, like were the voices of the people who helped produce this, part of the production of this, in a really community-based participatory sort of approach. That was one kind of wondering. And then I think Stefan was referring to this earlier, just with any kind of CAP survey, it feels like, the really dissatisfied and the very satisfied are the other ones and we're missing that huge swath in the middle that we want to hear from. So thanks very much for addressing all these matters. Big stuff.
Thank you. Okay, so thinking about how the survey was originally developed is actually including some patients as well. And thank you for those comments, Paul. All right, not seeing any other hands raised right at the moment. So Colleen, if I may turn to you to maybe address maybe some of these challenges. I think we're talking about response rates, which sort of gets into this validity realm that's really cross-cutting here. Thinking about the conflation of providers. I'm not sure if there's any exploration into that. Who are these patients? Are they biased in any way based to incentivize? And also thinking about the proxy issue. And I don't know if you had any thoughts on Paul's last question with the participatory involvement of patients in the development of the survey, but wherever you'd like to start there.
Sure. You guys gave me a lot of things to address, so I'm going to try to hit them all. And if I miss one, please bring it back up. So first, I just wanted to clarify the types of providers that we're measuring with this survey. So there's a lot of different CAPS surveys that go out. This one focuses specifically on long-term services and supports. And so we're talking about behavioral health providers in the home, personal care assistants, homemakers, and case managers. And so there might be other CAPS surveys that these same people receive, but when the surveys are administered, we have a very detailed guide that's provided to the states and then through their vendors to execute the survey in a manner that is very participant friendly. So the point you were making before, I believe it was Paul, about engagement of the patient or the participant, they've been involved since day one. I did not personally work on this when it was developed, but all of our documentation shows that participant engagement happened both at on the development side, so engaging participants in our technical expert panels, but then also ensuring that as we crafted the questions, that they were written in plain language and that they were designed to evaluate the experience that the the sample frame, their experience. And so we have engaged participants really from day one. We have participants on our expert panel currently. And so all of the changes that we've discussed here, some of the things that have been brought up for potential additions, those all either have been or will be presented to a technical expert panel that includes not only clinicians, but also participants and a variety of other stakeholders who might be impacted by these results. So when the survey is administered, there are additional ways other CAP surveys data are collected, but we have a very specific protocol for the HCBS population specifically because we want to ensure that we're getting the data from the participant themselves, not a proxy. So there's been some things mentioned about how, if you go to the hospital, you get a survey in the mail and anyone could complete it depending on who opens the mail. This survey is designed to be administered live. So there's no asynchronous completion. It's completed together with an administrator. And so it's done in person, over the telephone, or new can be done via video conference. And so a Zoom, essentially a secure Zoom, it could also be an option for this population. Our response rate. So our data show an average response rate of 22%. And so that value ranged from 9.8 to 31.1, depending on the state or the plan that we included in our sample. And these data are very much in line with other CAP surveys, especially for this population. So if we looked at hospice, I know hospice was mentioned before, they have their most recent data show a 29% response rate. So overlapping confidence intervals there. Medicare Advantage, 35.3%. And so the populations we're measuring have approximately the same response rate. Overall CAPS, we've seen just declines in responses to surveys in general. So if you go and look at data from 25 years ago, you could have a survey that had a 75% response rate, regardless of the topic. And it's just for every survey, it's gone down. People are completing fewer surveys. There's more declinations than there were 20 years ago. This is consistent across all surveys, not just CAPS, but all surveys that are collected from the public. I believe those are all the things I needed to hit on now, but again, if I missed something, please do let me know.
Yeah, sure. So thank you, Colleen, very much. So really some of the questions about the population and who's completing this and who's incentivized to do this, I think you mentioned there's really strict protocols here and how this should actually be completed and it's designed to be completed live in person using the various different modes that you had mentioned. Specifically with the mode, and I didn't raise this for you to answer the first time. So coming back on the mode, coming back to, I believe it was Sarah's question, why web or email is not preferred here? I don't know if you had any responses to that.
Yeah, absolutely. And so a lot of the conversation that we will likely have today will think about new and innovative ways for us to improve the response rate. So we want to adapt to the way that people work. Email or alternative types of responses like online wouldn't allow us to have that synchronous communication, right? So having a person on a Zoom, making eye contact on the phone, in person. And so as of now, email and web have not been tested, but it certainly is something we have CMS on the line that they're hearing that there might be an interest for it because I know other CAP surveys are administered that way. And it's something that we can bring back and discuss with the CAPS consortium and with our participants and other individuals who might have an influence. And so there's a number of things that may come up today that could appear in CAPS 2.0 as CMS works to refine the instrument.
Great, thank you so much, Colleen. So I think, the conflating of the providers, the proxy concern, and some of the incentives piece here, Colleen mentioning that there's this protocol and process in place to try to ensure that there's that interaction with the individual in conducting the survey live to try to mitigate some of those concerns that were raised or questions. But let me turn it back to the committee based on some of Colleen's responses, or do we feel fairly comfortable here with Colleen's responses related to either the proxy use here, the feasibility improving response rates, just to open that back up. Folks from the committee. Yeah, Morris, go ahead.
Hey, Matt. You might have answered it, Colleen, but I put it in the chat because it's a fairly complex thought, and I thought it might be easier to understand it in the chat. I'm just going to indicate that it's in the chat, and if you want to sit on it, come up with a response, that's fine with me.
So just drawing attention to that in the chat. So for validity purposes, are there weights or other procedures that you used to make the measure, yes, more representative. So thank you, Morris, for drawing attention. I did not cover that. So Norris, you also mentioned that CMS provides more data and you can do some statistical testing to make the sample more representative. Colleen, I don't know if you have thoughts on that right now. If not, we can circle back. Go ahead.
Yeah, so I did confirm with our testing team that we did not wait at this time, but it's an excellent suggestion. So thank you for that. We are really, it feels like it's been a long time since HCBS CAPS has been around, but it's really nascent in its use because, as I mentioned before, the access rule provides some more, some guardrails for states and plans to use experience of care surveys like HCBS CAPS and other measures to evaluate home and community-based services. And so I anticipate that as programs like Money Follows the Person, in which there will be a requirement to use an experience of care survey, HCBS CAPS is one of the options, that we will have more data and allow us to have more variety and more complex methods applied to our results. We do have some measures, as we'll talk about, I'm sure, for which there's some small sample size concerns, especially those for like unmet needs or personal safety. And so I think waiting, especially for those, might be a valid option in the future. So thank you for that.
Go ahead, Morris.
Sorry, quick follow-up, Colleen. I assume you, just in terms of implementing this, is Lewin the one who's in charge of implementing the CAPS? I might have missed that somewhere along the way.
Yeah, let me clarify that. So HCBS CAPS is co-owned between the Agency for Healthcare Research and Quality, AHRQ, that maintains the CAPS copyright, and CMS. This is CMS's survey for home and community-based services. So CMS is the steward that provides the guidance for implementation. Lewin provides the wraparound support. So we do all of the analysis for the measures. We have a technical expert panel to identify potential changes and vet them. We take data that have been gathered by other entities. So CMS has a different contractor, Westat, that maintains a database into which these data can be entered. So states and plans send their data to Westat. So we get those data and we do all the analyses. And so and then we also provide technical assistance to states. So we're doing also all of the support services and the analysis of the measures, but we don't, administration is kind of a complex term because there's a lot of owners for this.
Does that include the sampling strategy, who you reach out to, and kind of the parameters around how the survey is conducted?
Yeah, so in partnership with Westat, Westat and Lewin provide guidance in CMS's documentation on sampling, and so CMS has a manual that provides guidance on how to sample, how to create their sampling frame. Okay,
and this might be too complex of a question. I'm doubling back to where I started, just so it's clear. In that framework, do you standard things like oversampling, et cetera? What are the measures you take to do your best on the front end? Obviously, response rates are somewhat out of your control, but on the front end, what do you do to try your best to make the CAPS representative for the plans that you're surveying?
Yeah, so
Colleen,
yes, go ahead.
I'm sorry. I was going to say, Colleen, at any point you need some additional time, please take it. We can definitely circle back.
Thank you so much. Yeah, so that's an item for which I don't think we would be able to state that there's like a strategy in place yet, but you're pointing out things that as we have more data, we would anticipate there being application of more complex stratification to ensure that we have representative data by participant biological sex, racial and ethnic identity. There's a number of demographic factors. I think it's 15 different demographic questions that we ask. And so making sure that those demographic questions are indeed representative. I will double check that my team doesn't have anything else to add, but that's my answer right now, and I'll circle back in the chat or verbally if I do.
Thanks, Colleen.
All right, that's it for me. I'm done.
Well, Morris, I'm gonna put you on the spot here. So I raised some good considerations here, and I know Colleen is addressing some of those, circling back here. But is this something that is really jeopardizing your decision on a vote for endorsement, or is it something more recommendations that we can consider moving forward for the developer?
So for me, this would be a condition that they look into ways to make sure that the validity is representative. I do not think this jeopardizes my endorsement, at least for some of the measures. I have my winners and losers. We'll just say that.
Okay. Thank you for mentioning that and confirming that as well. I do want to do see Carol's hand and Stefan, your hands are raised. So Carol, let me go to you first.
Okay, I just have a real basic question because I want to make sure I understand this to one of Colleen's earlier questions. This CAP survey is administered face to face. That's in person. It's not by phone. It's not by whatever. So there's a surveyor coming to the person's home to get this information.
So that's one option. And so participants are contacted and they're given a choice of up to 3 ways that the survey can be administered. Not every state currently is using video conference. They can use video conference if they also offer in-person telephone. Everyone should be offering in-person and telephone.
Okay, and a follow-up to that, is it clear in that initial contact, just to try and reach them, that their services would not be jeopardized by their participation?
Correct.
Okay, thank you.
You're welcome.
Great, thank you, Carol, very much. And Stefan, circling back to you.
Thanks. I'll try and make this concise. So to that point about how surveys are administered, given the discussion of proxy and just from my perspective, the qualitative nature of this type of survey, I can understand why you wouldn't want to do text or emails. Regards to video conferencing, obviously we're talking probably about a little older population than the general population, but who knows? So video conferencing, I think it's a great thing going forward. There is an equity issue in my mind related to internet reliability in some areas. So that's something I think you should keep it on the back burner. Also, Morris was talking a little bit about skewing of the data and knowing healthcare a little bit. I can understand why perhaps more women are responding than men. And, that's such a deep subject, but so it's just an observation at this point. Splitting the mental health questions out from other questions, did you have initial thoughts about that?
Okay, thanks, Stefan. So hearing about the survey, the mode of administration, I believe there are options to consider. So if there is issues with internet availability, I think Colleen was mentioning that there could be other options to do this survey administration, both in person or even via phone. But it's also important to consider that not everybody has access to an internet or maybe even a potential phone. So, but there are some options to try to engage those populations as well. And then, sorry, Stefan, that last piece about differentiating, could you just restate that?
Sure. So basically, the short story is that one of the most striking examples of differences in responses is that the actual respondents skew heavily towards the female persuasion. I don't know what to make of that. I could guess, but I'm sure that's been in your mind. And if you have any initial comments about that, that would be appropriate to hear.
Thanks, Stefan. And before I go to Colleen on that, Kristen, your hand's raised if you have any thoughts.
Yeah, and Colleen might actually be able to help answer this one. So I want to circle back to that, the discussion or the question about how it's administered in terms of in person or over a video. And have you looked at any, I guess, the bias associated with that and response bias of people answering questionnaires in person compared to anonymously? I even think about myself as the pleaser personality of answering questions looking at somebody. So I'm just curious if there's been any discussion in your group or how you've looked at that. Or
thanks, Kristen. Another question around just bias with the patient population who's answering this, and maybe even just with the mode of delivery. Colleen, I don't know if you wanted to touch on Stefan's at all, and
yep.
maybe Kristen's. Yep.
Absolutely. So the population that we're measuring, so Stefan, I think the point that you made is correct, that there are certain populations from which we do receive more data. That's inherent in any sort of data collection effort, any survey. Generally, you're going to get more women. Generally, you're going to get more white people. And so I think some of the points that Morris was making earlier about the weighting would be important for us to consider as we expand the use of HDS caps to additional states. And then the bias question, Kristen, that you just mentioned, interesting. I actually have not thought about it. I'm sure there's publications that describe it. I don't have anything to bring up at this time, but that's definitely something that we'll bring back to our expert panel and discuss if there's any ways to manage it.
Thanks, Colleen. Great. All right, so Stefan, I still see your hand raised, but I don't know if that's a leftover.
It's leftover.
Okay, thank you. All right. A really great discussion around the feasibility of improving response rates. Really great suggestion here, as well as maybe exploring these different approaches, such as weighting to make the population more representative. I think that touches on a lot of the comments that have been shared. So thank you, Morris. But Morris also stating that doesn't really jeopardize decision for moving the measure forward, or at least some of the measures, as he stated, but could be a potential condition, and our team is sort of working through that here. I also share, I don't want to lose sight of what you mentioned about the incentives here to complete and how that could be something that could be a penalty provided. We will capture this within our summary, so I don't want to lose sight of that for you, and thank you for sharing that comment. Any other items here on cross-cutting pieces? I think we heard a lot of good discussion and some potential next steps for the developer related to condition, but anything else here? Drawing attention to the different modes. Obviously, Colleen saying that there's always ways to think about improving. CMS is on the call to hear about some of those opportunities and feedback, but there are some options with this survey. Anyone else on cross-cutting items listed here? Yes, Morris, go ahead.
Can you please progress the slide so I can refresh my memory on what the second slide was?
We can. So let's go to the next slide, and I'll still see if there's anyone else that has commentaries. I think, Aaron, you posted something into the chat. Any concerns about bias as it relates to the survey tool being administered? Okay. In person, yep, concern about services being taken away as a result of responses. So I think this comes back to maybe some other comments. I don't know if there are, Colleen, you wanted to address that question, this concern about services being taken away as a result of responses. But I think Aaron's first question kind of gets to what Kristen was maybe mentioning about how it's been administered and if there's bias with that.
Absolutely. And so I was informed by one of my colleagues that there was an analysis of types of bias for responses when the survey was originally developed. Now, the survey was developed and tested in 2016. And so these data are a little old, but I think still relevant. I've dropped them into the chat for you all to read. No real substantial differences, although there are some slight differences in the population from whom we heard, depending on the mode of administration. And I'll note that these data, as they were collected in 2016, at that time, we did not have a video conference option available. So you'll see that the notes apply to in person versus on the phone. And then the comment about bias for services being taken away, there is language in the letter that goes out to the individuals, as well as the introduction, that talks about how the data will be used and gives the person the ability to decline participation without penalty. And so that is clarified by the person administering the survey, as well as in the letter that goes out.
Thank you so much, Colleen. Aaron, circling back on you, if you had any additional follow-up before maybe we kind of see if there's other cross-cutting items. Not seeing anything else from Aaron.
Yeah, a quick follow-up question related to perhaps bias. Are there any considerations with language barriers? And yeah, I see you shaking your head, Colleen, so maybe I'll let you dig into that. Thank you.
Well, Aaron, was there anything else beyond that, or just that question? Sorry.
Well, I guess language barriers related to, that letter that is sent out to inform patients of their participation, as well as sitting down with a patient and being able to answer questions. Have we limited our potential population who can be involved in the measure, in the survey, as a result?
Thanks, Aaron. Colleen, go ahead.
You know, Erin, that's probably going to be my favorite question of the day. We are working on translating the survey into, I believe, 15 languages. So currently we have it in English and Spanish. And as I noted, we're translating it into the most common languages for this from, that we've heard from the states with whom we work. So we have several Asian languages, Chinese, Japanese, Korean, mostly on the West Coast, we see those, and then we have Haitian Creole, Portuguese, etc. So we're trying to hit all of the major population groups that would be covered in the states that have used this survey. It's very important to us that we are able to collect as much data as is feasible. Of course, the state would need to have would need to work with the vendor to ensure that they have a person who speaks the language and can administer it. So that is a step that we have not yet analyzed because we are still preparing the new versions of the survey, but that will be available either later this year or early next year. Our work will end in about a month on that. And then the questions about just language in general is documented within the survey. So one of the 15 demographic questions, we do note that the person's level of English, comfort with English and the language spoken at home. Similarly, we do also note the education level of the individual. And so we don't have enough data to make meaningful interpretations from these variables, but I anticipate that as time goes on and more states begin to use this, ideally also increasing the response rate through some of the improvements we've discussed today and with the advisory committee, that we'll have the ability to present more advanced statistics on those data in the future.
Thanks, Colleen. And sorry to throw this in there too. Carol just added too, related to language, there's also health literacy. So any thoughts you want to share with the committee on health literacy aspects of administration? Go ahead.
Yeah, so we asked about education levels, so that's probably the best data point for that question. We also do ask about the individual's physical and mental health to rate it on a scale. And then the final note I'll make is there is a way to simplify the questions that are being asked. So the scale, yes, you're absolutely right, Carol. And that's definitely something that we'll bring back to CMS to see if there's a way for us to gather this data moving forward. We don't do that currently. I will note, oh, yes, so the structure of the survey can be simplified. So currently, it's a 4-point scale. It can be done more like a yes, no than a sometimes versus always response. And so we try to make the questions have been designed to be as simple and interpretable as possible, and that the person administering the survey has the ability to use the simplified question structure if they so desire, depending on how their conversation goes.
Great, thank you. So thanks, Carol. I'm thinking that the literacy in the letter they receive initially. Okay.
Yep. So I believe we use a 7th grade standard. We do use plain language. CMS has guidance. Yes. Okay. Thank you for that feedback. And so CMS has guidance that plain language standards generally are 7th grade for the materials that are posted publicly, but appreciate the feedback. And that's definitely something that we can explore in the future.
Thanks, Colleen. So Morris, you've got your hand raised. Again, thinking about cross-cutting topics here. We're still talking about how the survey's delivered and some considerations here. Please go right ahead, Morris.
Yes, so as a cross-cutting topic, I'm wondering, Colleen, or if you could talk about the variation in validity. I imagine partly it's just very difficult to present 19 different types of measures all the same way, but if you can speak to kind of at a high level cross-cutting level about your choices for validity test as well as risk adjustment, I'd appreciate understanding the logic.
And Morris, if I could, maybe we'll circle back on that. That's definitely getting into some of the more nuanced areas, and I think an overview from Colleen would be helpful. So if that's okay, Morris, if I could circle back on that one before. Okay.
Perfectly fine. I just want to make sure it's discussed.
Yes, thank you very much. Okay, any others here? And Carol, thanks for those recommendations for Colleen to consider. Marguerite's coming off camera here. Any others, especially, again, thinking about, you still have significant concerns that's going to question your endorsement based on the discussions around these response rates, survey mode of administration. Again, we heard that condition from Morris. Anything else questioning your decision on endorsement for cross-cutting? Okay. And Morris, I'm definitely going to come back to this. I did want to shift us here to thinking about some of these nuances. Morris started to talk about the validity piece, but maybe I can just revisit the use and usability here. This wasn't a very, in the comments that we saw from our recommendation group members, there wasn't a huge concern listed here. Again, there's thinking about use and usability. We have, is the measure being used, which it is. And the other thing here is there is a feedback mechanism, which there definitely is, as Colleen has been mentioning, hearing from the states, improving that, the survey instrument, taking that into consideration. But there's also this component on if it is being used, is there progress on improvement over time? So in the submission, the developer did provide sort of two data points to compare, 2022 and 2023. And they looked at several measures, but 6 were sort of missing, largely around the case manager measures within some of the domains, but also the physical hit or hurt as well, and also some of the unmet need measures, the meal preparation, medication administration, household tasks, really equating to about 6 measures that didn't have this improvement over time. And from the recommendation group, some members said that this isn't really questionable for them. Most likely if there's improvement on these measures that were shown, there's probably some improvement on the others that were not shown. But maybe Colleen, is there any sort of response you want to provide for the 6 measures that weren't included in that improvement results of why that's the case?
Yes.
If you need more time, we can circle back. Okay.
My colleague is typing, so give me just 1 second on that one.
Okay. All right, that's fine. And let me, I'll turn to Stefan since you have your hand raised, Stefan. Let me open it up there. And Morris, don't worry, I'll definitely come back to the validity.
Okay, I know we're moving at a really fast pace, so I just posted it to the admins. I would like to consider a condition that would move towards separating questions related to mental health from the other questions and see if it's possible to target those people. Again, I realize it's 2 steps removed from the survey design, but when you administer a survey like that, I just know that some people are going to be less likely to finish the survey if there's a lot of mental health questions or, other questions that are really targeted towards one population. So I'd like us to think about that.
Thanks, Stefan. And I know, Colleen, if you have initial thoughts on that, sort of separating out those with mental health or behavioral health conditions in any way with survey items or any sort of analyses you have related to that patient population.
Yeah, thank you for the question. So 2 points. So first, related to behavioral health providers and homemakers. So those 2 provider types are currently combined in the way that we gather information about the service providers through the survey. It is something that we are exploring to try to separate out so that homemakers and behavioral health providers have different questions. So that is something on which we are working. For the participant population that is receiving HCBS because of a mental health or substance use disorder diagnosis, this is a very important topic to us and to CMS, and so we are taking a close look at those data. I will say that many of the waivers through which individuals qualify for HCBS and thus end up in our population, they don't tell us why the person qualifies. And so a lot of them are like healthy choice, and so that could be anybody. And so the challenge is that some waivers are very clear. We know that it is acquired brain injury waiver or a mental health and substance use disorder waiver. And so we do analyses to the extent possible for those, but for the mixed use waivers, it's more difficult for us to analyze specifically the experience of care for mental health and substance use disorder participants. So we're trying, and as much as we can to the extent possible, we're doing that analysis.
I appreciate that response, and I wasn't asking you to be perfect.
We're trying. Thank you.
Thanks, Stefan. So Colleen, anything you wanted to, circling back on the use and usability element, and maybe we can kind of shift to our testing and reliability and validity, but I'm not sure if there was any follow-up response to that. We can always circle back to it.
Yeah, so I mean, we do present 2 data points for each of the 19 measures throughout our package. You are correct that there are some for which we did not see substantial improvements. I would say that the challenge at looking longitudinally at 2 data points is that they could be representative of change over time, or they could just be 2 data points. And so because of the nature of the way that these data are collected, you know, we receive some data from states, some data from plans within states, and not every year everybody provides the same set of data. It is difficult to do comparisons over time. That said, we're seeing increases in use of the HCBS CAHPS database, to which I made reference earlier. More states this year than last year. It opens again in August. We believe that as more data are collected, we will be able to provide more meaningful insights of improvements or declines over time. And so it's something on which we're working, and we do believe that additional data would be needed to actually present either benchmarks or trends, since these 2 data points don't really, I don't think they tell a fabulous story of improvement over time. Oh, and just the final point I'll make here is that we ended up losing a lot of data because of the COVID-19 public health emergency. And so some states were administering HCBS CAHPS during that window. That's why we added video conference, because of the whole way our lives changed for a while, and still ongoing. But the data weren't quite as usable as the data from 22 and 23. That's why we chose to present the package in the way that we did. And we believe that, again, as life has returned to normal-ish, and we're able to gather data that we think are cleaner, that will be able to tell a better story over time.
That's great. Thank you, Colleen. And again, drawing attention that some of the recommendation group members, didn't find this to be a major concern. Of the measures not included, suspecting that if all the others improved in those 2 data points, some of the other measures included may also have improvement as well if they were not looked at. But before we start getting into the nuances with the testing, any concerns about the use and usability aspect? It really was drawing attention just to those measures that were not, did not have data points to show improvement. Again, there was just 6 of them, but not hearing major concerns through the recommendation group, but I'm opening up for others here. No concerns from me. Thanks, Morris. Okay. All right. Okay, so for reliability, there were 4 of the 19 measures that had low reliability. Again, we're looking at that accepted rate, a value of 0.6 through a signal to noise type of analysis. And then we have some validity areas here. And Morris, I know you drew attention to validity, but so let me just first state, Colleen, can you provide maybe just a brief summary of the types of validity that you did as Morris's question, and then we can kind of shift to going through these a little bit more in detail.
Yes, sir. So our reliability and validity testing was complex because of the nature of the 19 measures that are included in our package. And so the measures are structured differently. The measures have different amounts of data. So some were easier to analyze and some were more difficult. Overall, the 4 types of validity assessments that we performed were construct validity, convergent validity, discriminant validity, and face validity. I can define those for you if you have questions, but they are detailed response for each type of validity is presented in our package with results for each type of test. And essentially the tests were chosen based on precedent, so some testing that had been done historically for a previous submission, as well as methods recommended within the literature for the structure of the measure.
Okay, thanks, Colleen. And we'll get into more of the detail here, because Morris, you may have some follow-up here. But let's at least first and open it up to our first domain. So I'm going to ask the team to screen share our first domain, and you can see the measures listed within that so that we can all orient ourselves. So again, we're going to assess these measures by the domain, just considering also just those measures within it and any of the nuanced testing related to those. So if we can get that pulled up, thank you. Okay, so first is the scale measures. This was included in the discussion guide. This is the numerator. You can see those 7 there. Looking at staff are reliable and helpful, case managers reliable and helpful, staff listen and communicate, et cetera. You can see those 7 listed there. Now, of these 7, there was one of these measures, which is case manager is helpful. So that's number 3 there. Case manager is helpful is number 3. So this is based on 3 survey items. So if we can flip over to the reliability table and orient you what you're seeing here. So the reliability is looking at just this distribution of these reliability estimates over these accountable entities. And really, it's broken out into deciles, right? So when we look at the reliability statistics, we're looking at this distribution and we're trying to see how many of these entities, which are again broken out by deciles, have a reliability estimate of greater than or equal to 0.6. So what you can see in yellow is where that was not achieved. And you can sort of argue that a 0.57 or 0.59, if you round up, it's 0.6, right? But for that scale measure, which is that last or second to the last row, you can see that decile 1, 2, 3, 4, and 5 has about 50% of those accountable entities that didn't hit that 0.6. So that's why we drew attention to it. And so that was one of the nuanced issues with the scale measures. Okay, if we can flip back to the PDF, again, I want to focus our attention on those issues that we found with those nuances from either staff assessment or recommendation group. We did have recommendation group members draw attention to that one case manager is helpful measure in this domain. The validity didn't have too much of an issue here. As Colleen said, there were some analyses that they did here, confirmatory analyses, correlations with other subscale measures. The correlations looked fine, and the confirmatory analysis with validity looked fine. And there was also risk adjustment done on these scale measures, and this risk adjustment was performed on these. So that's not something we drew attention to in the staff assessment. It was really that reliability testing. So I'm going to pause here. If a committee member has any questions about any of these measures that really you need because you're concerned about the endorsement, please go ahead and call it out and state your question. And I also will circle back to Morris too, because I don't know if you had any questions specifically with validity for any of these scale measures. Again, we're just thinking of the scale measures at this point. Any thoughts, questions? Yes, Morris, go ahead.
I do have a question. I just don't want to jump everybody else in line, but I had trouble understanding sort of the difference for the reliability testing and what you guys were attempting to measure for IUR, ICC versus the entity level Adams testing. Because, you know, what Matt pointed out about the case manager is helpful. It is a data point, but then when you look at the IUR and the ICC, you see 0.75 and 0.6. That might put people at ease. I just want to make sure that we collectively as a group understand what are the differences there and what's the interpretation that you would bring to what you're finding.
And Colleen, if we need to go to one of those tables, that's fine, but sort of thinking about, you know, what's the interpretation of those tests? And if there's an exhibit that we need to go to within the reliability testing, we can do that.
Sure. So I'm going to have one of my colleagues jump in here since I don't want to explain this incorrectly. Let's see. So I'm sorry, Morris, could you repeat the question for me?
Let's just focus in specifically on case manager is helpful.
Yes, sir.
So Matt brought in the entity level testing results where you have a median of 0.59 and a mean of 0.51. Then we also have these other three testing results, the Cronbach Alpha, the IUR, and the ICC. I want to make sure I understand the difference between all these tests and your interpretation. Specifically, let's just do case manager is helpful. I imagine the discussion will apply to the rest.
Of course, yes. I'm going to have actually, Patel staff, could you do me a favor? Could you elevate Gary Rizik? He's one of the attendees. He's my tester, and so I don't want to get this wrong.
Yes. If he can raise his hand on the attendee side, we can promote him. And I think what Morris is pointing to is Exhibit 14. So if we can just scroll up there just to see Exhibit 14 with the different tests here. So these are these other reliability tests that Morris is referring to, and kind of, you know, the rationale and decision making for those. So we do have, I believe he is on now. Okay. And is your colleague on here?
Yes, he is.
Okay.
Gary, just
Feel
let us
free
know
to.
when you're ready.
Yep.
Yeah, hi everyone. So in order to kind of explain the sort of disparate result in the entity level reliability score, so where we were looking at the deciles where for case managers helpful it's low. To be honest, I will need to dig into the sort of looking at the performance scores for that measure in particular to see if there's a particular sort of lack of variation between agencies we looked at, or potentially, um, a lack of sample size that could explain why the signal to noise reliability score is appearing to be sort of lower than what we saw with IUR.
And I'll note that the number of responses that we considered valid for this specific item is lower than the others within the scale measure type. So the response rate and just the availability of the data certainly drove the overall mediocre performance for the reliability of this measure.
Okay, thank you. Yeah, so Morris, I'm not sure if there's any sort of additional question you have here. I'm not sure if that was fully addressed for you, just why some of these other tests were conducted, unless you wanted to kind of dig in a little bit further.
Yeah, I would appreciate a little bit more clarity, Gary, if you could provide it on fundamentally what I mean. I see the labels. The entity level testing is entity, so I assume that's state or HCBS plan. The IUR and the ICC, they're listed as participant, and I just want to make sure I understand at a high level, if you can, what are we testing here, and what's the difference between the
Yeah, so participant in this case would be the agency. So yep. And again, to explain the that sort of disparate result in the follow-up table here, which presents the deciles, I at this moment I don't have a good explanation other than where Colleen may have pointed out there's a smaller we had a lower response rate, so fewer cases to work with. And again, I would need to look at sort of the entity level population for each entity, I think, to explain why these appear lower.
All right. Thanks, Gary. So yeah, Morris, I'm not sure we're getting the answer you're looking for with IUR versus some of these the signal to noise here. Through the analysis that we did, we looked at the accountable entity level testing and the signal to noise, and obviously pointed attention to this distribution in this one measure. But Morris, I guess coming back to you, thinking about these other tests that were provided, maybe not, if you're not hearing that response, is that going to sort of question your ability to move forward on endorsement?
It's not. I mean, it's probably just intellectual curiosity, man. I mean, when I look at 0.59 as a median reliability, given the mitigating circumstances that Colleen and Gary suggest, this isn't reason for me to even put a condition on these specific measures.
Yeah. Okay.
And I appreciate your comments, Morris. I want to and apologize if I just didn't have all of the data to sort of answer that one specific question for that measure, but I appreciate your question.
Thank you. I guess, Gary, just a quick question. Is the Exhibit 14, which is the table above, is that a person level? Are those person levels? Because Exhibit 15 is accountable entity level. And so are these person level versus the accountable entity level? And I know this is kind of getting a little bit in the weeds for others on the call. Okay. Maybe we can kind of circle back, because reliability will kind of come back with that as well. So I don't know if there's some clarification when we get to some of the other measures of reliability on Exhibit 14, but for the accountable entity level, which is Exhibit 15, that's where we drew attention to in the staff assessment. Some recommendation group members also drew attention to that. So again, that case manager is helpful. Data point, thanks for scrolling up and down there, Anna. That is where we receive about 50%. I know that decile 6 is included, but you can argue if that's really 0.6. That's where we see about 50% being of those entities falling below that expected value, 0.6. And we did hear from Colleen that this received a lot of the low sort of responses, so probably factoring into why we're seeing those response rates there. Stefan, you have your hand raised. I wanted to see if you had a question related to this, or did you have a question related to one of the other scale measures?
It's actually related to the detail that's showing here. So I have two comments. One is just a correlation between two of the questions here. You have case manager is helpful and reliability and levels are very low with that. Again, that possibly might be due to the number of data points you're looking at. But as a patient, I find it interesting that that question seems to be low, but if you look at the recommendation of case manager, the validity seems to be much better there. As a patient, that makes me scratch my head a little bit. And I don't want to presuppose anything about the underlying data, but as a patient, when I think about my caregivers, the people, you know, from the orderly that cleans the bathroom to the physician, to the surgeon, to whatever, the last person I'm focused on is the case manager. I don't want to read into the details back here, but that's my perception of what's happening. Take it for what it's worth.
Yeah. So drawing attention to, case manager getting some of that low reliability, but then the recommendation of case manager is high. I know the response rates on this case manager's helpful item were a little bit lower, but thank you for that point, Stefan. Colleen, I don't know if you had any thoughts on Stefan's point, maybe why there's that difference here.
Yes, absolutely. So they are different questions that are being asked about the case manager. So my interpretation of these data would be that we look at the 3 questions for case manager is helpful. I'm just going to read them. So in the last 3 months, could you contact the name of the case manager when you needed to? In the last 3 months, did the case manager work with you when you asked for help with getting or fixing equipment? And in the last 3 months, did the case manager work with you when you asked for help in getting other changes to your services? So those are the 3 questions that feed into that scale measure for which we have the median reliability score of 0.47. In contrast, the question that's asked about the case manager within the recommendations set is, would you recommend the case manager who helps you and your family to your family and friends if they needed whatever case management is called by the state or the plan? Would you say that you recommend his or her name? And so there is a connotation that is associated with that single question that I would not read into the 3 questions that are created into the hybrid scale. Stefan, it looks like you disagree.
No, I'm just giggling about this because having worked with enough surveys, the languaging is very interesting.
Yes.
How many times do I recommend somebody I really, really like to anybody? Well, and God forbid they should need a case manager. As from the patient side, you have to understand the lens that they're seeing things through.
Mm-hmm. Appreciate that. Thank you.
Thank you so much. Okay, I want to see if there's any, Paul, you have your hand raised, but again, are there any other concerns here with any of these other scale measures? And let's maybe flip back to the list of those, because I do want to get us moving on voting on some of this as we get through some of these other areas. But Paul, go ahead.
Well, on that last slide, I guess I find myself stuck a little bit along reliability as a past issue. And I guess I wonder, I always think of that whole line around, I felt heard and understand as one of those metrics that has always felt the most important to me. I wonder if you could just comment a little bit more on the staff listen section there.
So, and Paul, specifically the question just asking what that means, the staff lets them communicate
a little
well?
bit about how it's done, and there seemed like that had quite a few more numbers to it and things. And stuff.
Yep. Yeah, reliability looks
Help me feel less unsettled, I suppose.
Okay. Yeah, go ahead, Colleen.
Sure. So for this one, there's a lot more questions. I'm actually going to drop them into the chat, Paul, rather than read them, so I don't take 4 minutes to read the 9-ish questions that there are. But they do ask about a variety of experiences that are conducted between the personal care assistant and the behavioral health staff member. And so actually quite a variety of things that are covered under this scale measure. So here you go.
Yeah. Yeah, and then Paul, for this one, you know, the reliability was higher, right? So only about 30%, as you can see, 3 deciles, 30% of those entities fell below that 0.6, which, you know, that's still a sufficient number of entities that are actually having a good reliability based on this measure here in the survey items.
And I apologize,
Okay.
Paul, I actually cannot paste it. It's too much text. So I cannot paste it into the chat. But I'm happy to answer a specific question if you have one.
Yeah. So Paul, is there anything specific here? I do want to see if we can try to move to getting to voting on these if possible, but anything that you wanted to add to your question? Apologies, we couldn't provide those questions.
I guess it's fair if you're getting 70% are okay and 30% or less, it's probably all right. But in the context of the others, that's fine.
Oh, thanks, Paul. Thank you. All right, so let me open this up. So not hearing any other specific measures to really discuss. We talked about this case manager is helpful because of the reliability being at the accountable entity level. So being 50% less than that expected value. That's why we drew attention to it. So not hearing some of the others listed as these 7 are causing any major concern or questions, I'd like to move to a vote. Now, for all of these measures that we are going to be voting on, there will be sort of this condition here across the board that we want to place on the measure, which is, yeah, obviously when the measure comes back for maintenance, we would like the developer to explore methodological strategies, weighting and sampling to ensure that responses are representative. So I'm just going to turn to Colleen if you had any thoughts on that condition before we proceed to the next group of measures. Does that seem reasonable?
No concerns on our end. Thank you.
Okay, thank you. All right. And then Stefan, Kristen, I think thumbs up on that condition from you, right? I think we confirmed that. Okay, great. So let's open it up to our first vote on these measures. Again, we're just try to do this quickly. So it'll be voting on each one of these measures. Not hearing any of those concerns for those measures, again, you can definitely vote to endorse if you don't think the condition needs to be placed, or endorse the condition as well, hearing Morris's comments and how reasonable that might be. And then, of course, the removal of endorsement. So Isaac, let's turn it to you to go through our first measure here.
Voting is now open for measure 2967, the HCBS CAPS measure, and this is the scale measure 1. Staff are reliable and helpful. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. We are expecting 14 votes.
And Morris, just drawing your attention, you're not recused from this one, so please go ahead and vote. For folks, if you're try refreshing your screen too, if something's not popping up on your end.
We have 11 votes in.
Any difficulties from anyone?
Waiting for one more vote. Sujin, are you able to send in your vote?
I think Sujin had to leave this afternoon, so she's not here. So that drop us down to 13. Isaac?
So we're at 14.
Still at 14? Okay.
So are we good?
Yes. We can go ahead and close the vote. Voting is now closed for measure 2967 for the first scale measure. We have 5 votes for endorse, 9 votes for endorse with conditions, and 0 for removal of endorsement. Between the endorse and endorse with conditions, the committee votes to endorse this measure with conditions.
Thank you. Let's go to our next. So everyone can be at the ready here. We'll just move right along.
Voting is now open for measure 2967 for the second scale measure. Staff listen and communicate well. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. Waiting for a few more votes. If you're having difficulty sending in your vote, please try refreshing your page. And if that doesn't work, try using a different browser. Waiting for 4 more votes.
Anyone having issues?
So we're missing votes from Andrew, Cher, and Jeanette.
Andrew, Sharon, Jeanette, if you wouldn't mind submitting your votes, if that's okay here.
Waiting for the last vote. We have all 14 votes. We can close it. Voting is now closed for measure 2967 on the second scale measure. We have 3 votes for endorse, 11 votes for endorse with conditions. Between endorse and endorse with conditions, the committee votes to endorse the measure with conditions.
Thank you. So I'm going to propose something because I think the voting is taking a little slow here. So if it's okay with the committee, since the other measures, except for maybe the next one that's up, which is the one with the reliability, did not get discussed or concerns in any way, is the committee okay with moving those measures to the same type of decisions that we're making here with endorse with conditions? If you have any concerns with that, you can direct message me. So there's some yes, yes, yes. Okay. I just want to kind of move the conversation along. If you have any concerns, please speak up. If not, we'll just vote on the next measure and then we'll go to the next domain and then we'll apply the endorsement conditions decision to the other measures. Okay. All right, thank you. Okay, great. So let's go to the next one. So again, this is the measure with the reliability, and I had 50% of the entities less than 0.6.
Voting is now open for measure 2967 on the third scale measure. Case manager is helpful. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. Voting is now closed for measure 2967 on this third scale measure. We have 2 votes for endorse, 11 for endorse with conditions, and 1 for remove endorsement. Between the endorse and endorse with conditions, the committee votes to endorse the measure with conditions.
Okay, thank you. So the other measures would still have the conditions apply for these scale measures. So thank you very much. Let us please go back to the next set. I'm gonna kind of move this along a little bit quickly here, just because of the global and recommendation group measures kind of have the same types of considerations here. So if we pull that list back up, so we have the global rating and the recommendation measures. We'll do those next together here before we go to unmet needs in the last measure. So these measures did not have any of the reliability issues that we identified previously. In addition, the developer did conduct some validity testing on these measures, some correlation analyses to other subscale measures. There were some correlations that were low and some that were fairly moderate. And risk adjustment was performed in the global ratings, but not the recommendation group measures. So exhibit 37 of the validity testing here, you can see these correlations. So the larger the number, the higher the correlation, but the lower the number, the less that correlation. And then of course, there's statistical significance here. So Colleen, I wanted to see if you had any rationale for some of these low correlations versus moderate, and is that something that you could provide some clarity on?
I'm going to need my colleague, Gary, to weigh in here as well. Gary, if you wouldn't mind jumping in.
Okay.
So yeah,
and well, maybe go ahead, Gary.
I think just to explain sort of the differences in these correlation results in these internal items, I don't know that I can speak to sort of why some of these items would have lower correlations. I don't know if one of our other colleagues on the line, perhaps Chris or someone could maybe could speak more knowledgeably about the individual items content wise as to
Sure, I think so.
why
For
the correlation may be.
So for the personal safety and respect, I think there's a very low variation in responses, which would affect the correlations between the global ratings of personal assistance staff. So that's kind of one thing you would probably see there. So you probably see that between for those listings for the homemaker as well as the personal assistance staff. And then for some of the correlations between global rating of the case manager and case manager is helpful. I think what we would say, Colleen, you already kind of mentioned sort of the difference, but that sort of these two, one is sort of a composite of specific elements of this. And then also you mentioned that this other is sort of a difference in terms of sort of like the recommendation of someone as opposed to some of the specific sort of.
So it's interesting because the questions are measuring different things, right? So case manager is helpful as evaluating a different construct than the overall global rating or the recommendation of the case manager, just to use that as an example. And so some of our questions do look back at the 3 months. So a person is surveyed in May. You're looking back 3 months from May to determine if they've had specific things happen or not happen. Whereas something like an overall rating or a recommendation talks more about the experience that the participant has with that individual more broadly. And so sometimes it's difficult because like a case manager, as an example, may only see an individual for whom HCBS is needed intermittently twice a year. And so they might see them just so infrequently that when we try to speak to the specific services that have been provided in that short 3-month window preceding the survey execution, they're not able to say, oh yes, my case manager, Sally, was able to provide me with durable medical equipment that I needed because the services aren't provided with that frequency.
Thank you, Colleen, for providing some clarity there as well. And Morris, you kind of drew attention to some of the validity differences. Did you have any questions here?
Not for these measures in particular. I actually view these as very promising. You don't want something that's 0.9 here because that means they're the same measure, and what's the point of doing it?
Great.
So we've got some values between 0.2 and 0.4. That's typically what I would like to see. And then the ones about personal safety and respect, I imagine pretty much everybody said,
Yes.
you know, I feel respected and safe. And so that's why you're running into an almost zero value there. So yeah, I'm fine with this.
Yeah, if I
Thanks,
could just
Morris.
jump in and just add a little bit of color. We would, as you know, expect to see values above 0.7. Why have two separate questions? We already know that the survey is quite long. And so by demonstrating that we only have these moderate correlations, we're providing the value of having the different questions. And then as you noted, Morris, and this will be applicable to when we talk about the personal safety measure, that there's just such small variation because there's not, thank goodness, a lot of injurious happenings. And so individuals for whom care is provided by these HCBS providers generally do not indicate that there's a safety risk. And if there is, that's a very strong indicator that something needs to change.
Thanks, Colleen. If we go back to the list of measures, I did also just want to ask Colleen, just you know, why risk adjustment maybe wasn't done on the recommendation measures. It was performed on the global and scale, but do you have a, yeah, go ahead. Yeah, sure. No worries. How about we could come back to that if needed. Okay. So let me just go to the vote on the global ratings measures. But first, committee members, global ratings measures, there's 3 of them here. Any questions you have that's going to question your value or question your decision on endorsement for these measures? For the global ratings, we'll circle back to the recommendation group. If not, Morris, yes.
Just wanted a clarification. The condition that I had stated was cross-cutting, and so I would like that condition to look at weights be applied to all of the measures we're talking about for this number.
Yes, thank you, Morris, for raising that. It will be, so all that condition is going to apply for all of these 19. So keeping that in mind. So any other questions on those global rating ones before maybe we go to a vote? And again, not hearing any, we'll vote once, and then we'll apply that to all 3. So now's the time to raise up. Oh, yeah.
And Matt, just before you begin voting, the recommendation measures were not risk adjusted because it's only a single question. And so the logic did not apply there. That we'll see that similarly for the hit or hurt by their staff as well. And so single measures we can adjust based on the way that the risk adjustment schema is developed.
Great, thank you. Any concerns from the committee on that? Okay, before we go to the vote on this one, I will also say that if you any other questions on those recommendation group measures from the committee, based on Colleen's response here, we heard Morris's thoughts on some of the validity testing, but for the risk adjustment, I think that was appropriate. Okay, so what I'll do here is maybe we get these 6 out of the way. So let's vote one time. It'll be for this global rating measure, but then from there, we'll apply the same condition and the same scores to the other global rating measures and the recommendation group measures since we didn't hear any discussion further on that. So what you're voting on is all 6 of these measures right now, and the condition is still the same, is that they will explore those different types of approaches like weighting related to all of these measures. All right, Isaac, go ahead.
Voting is now open for measure 2967, the HCBS CAPS measure. We're voting on the global rating measure 1, global rating of personal assistants and behavioral health staff. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, or remove endorsement. We have 12 votes in so far, waiting for 2 more. Sujan and Andrew, are you able to send in your votes?
I think Sujin's not with us right now, but if Andrew's on. How are we doing, Isaac?
Still waiting for Andrew's vote. Andrew, if you're unable to send the vote in, try refreshing your page. And if that doesn't work, you can send your vote directly to me via the chat. We have all 14 votes. We can close the vote. Voting is now closed for measure 2967 on the global rating of personal assistance and behavioral health staff. Based on the evaluation of this measure, the committee there are 2 votes for endorse, 12 votes for endorse with conditions, and 0 for remove endorsement. Between the endorse and endorse with conditions, the committee votes to endorse the measure with conditions.
Great, and that will go for all global rating measures and recommendation measures, so thank you. Last set, I know this is, you've all been hanging on, so thank you very much. We can see if we can get through this, maybe take a short break, give Colleen a break before we just do our last measure. I know it's been a long day, so thank you for bearing with us. Just make sure to vote when you get that opportunity. So let's revisit the unmet needs, and we also talk about the physical safety. So with the unmet needs measures, you can see, we'll pull up that list there. There are 5 of those. In the physical safety, there's just 1. And with the unmet needs measures, there we go, you can see those. So unmet dressing and bathing, meal preparation, medication administration, toileting, et cetera, and household tasks, and hit or hurt staff. With the unmet needs measures, there was definitely some questions related to face validity testing that was done just for these sets, but no other empirical testing was done. Also, no risk adjustment was done on these measures. There was also no risk adjustment done on the physical safety measure, but as Colleen mentioned, single item measure, that's why they did not risk adjust for that. But also face validity was also done on the physical safety measure, but no empiric analysis. So there are reliability also issues here for 3 of these unmet needs measures. We'll just show that table that we saw before. So you can see listed here where those distributions for those 3 down at the bottom of that row, where you have about 60 or almost 70% of the entities falling below that expected value of 0.6. So that is a larger number than what we saw with that 50%. Keeping that in mind, but we have those differences listed there. So Morris, let me open it up to you because I know you've been kind of waiting on this. Let me sort of just see if you have those initial comments or questions here related to validity testing before maybe the developer has any thoughts.
Thanks, Matt. I've been chomping at the bit. No, honestly, I appreciate the format for which these measures are created, but especially for the bottom 3 unmet need, the reliability just isn't there. I'm not convinced that response rates are going to get high enough so that reliability will ever get there. I can't recommend these 3 measures in particular for endorsement. The others which have sufficient reliability, I'm going to take a leap of faith and assume that the numbers will stay there going forward. That's not a guarantee, but seems, based on what they're actually measuring, that could be the case, and say that these are sufficient to, at least for me, to endorse with conditions, the condition I previously stated. That's where I stand. It ultimately comes down to sample size, reliability testing, and frankly, these don't pass. So that's where I stand.
So just referring to these last 3 specifically, Morris, right, is where you're feeling concerns with?
Correct.
Yeah.
Yeah.
Any thoughts about the validity for these? I know you mentioned asking for the differences across these domains, but this one just did face validity as well. And it's scrolling down to this table of comparison where they kind of found there's moderate or low to moderate types of agreement with the technical expert panel that they had for all for all of these measures in the unmet needs and physical safety. But Morris, I don't know if you had any thoughts on validity or it was just the reliability.
I was more concerned about reliability. Obviously, a low is not as good as a moderate here. I think, I think we'll rely on the collective wisdom of the recommendation group and the expert panel that was interviewed for face validity. For me, I'm more in the moderate camp than the low camp, but that's me personally, and this is always kind of a judgment call.
Thanks, Morris. Others on the committee, so we heard these 3 unmet need measures is one area that we may have to have a separate vote on. But others on the committee, any other thoughts on some of these other measures? Anything flagged for you as a concern? Sarah, go ahead.
Thank you. Can I just have a bit more clarity of how the question is asked in terms of the respondents' understanding of what help means? Is it specifically help from the program, or are they expecting other help? I guess that comes to the validity piece I also have some concerns that have experience with other patient-reported outcomes when help may be perceived as financial help, or help may be perceived differently than what the service is intended for that's being measured.
Thank you, Sarah. And Carol, your hand's raised as well. So Sarah asking a little bit more about what help means, how is that asked? So we'll circle back with the developer, but Carol, go ahead.
Yeah, I have questions similar to Sarah's, and I'd really like to know how these questions are asked, because when I look at these items, and these are home-based services, they're not 24 hours a day. These are complaints I hear all the time from people receiving home-based services because their aide can't touch their medicine, but they can remind them, or there's not somebody there to help them get to the toilet 24 hours a day. And I'm not saying that's not a problem, but that's not what the service is designed to provide. So I'd really like to know how the questions are framed, because these are almost setups to say I'm not getting as much as I need.
Thanks, Carol. And agree. So with Sarah's question there, Stefan, please. And, oh, Stefan, you're trying to speak. You've got your hand raised.
Yes, there must have been a lag in the audio. So I don't want to piggyback too much on the experts. They certainly have a vast amount of experience. I would phrase those same sentiments this way. So you have to ask if the expectations of patients are reasonable. Now that's not a loaded question. It's like, you know, people that are receiving these services are in a world of hurt already, right? So if we believe that the patients are asking for things that are reasonable and in scope within healthcare services, then, you know, it seems like we need to figure out ways to get more responses. But if they're not reasonable expectations, given the state of our healthcare system in general, then we need to not ask the question.
Thank you, Stefan. So drawing attention, are these reasonable things and expectations to ask? Maybe that's why we're seeing some of these low response rates. Any other comments from the committee on the unmet needs or the physical safety piece before I turn to Colleen to maybe she wants to speak to some of the comments around how these questions might be asked? And Colleen, if you had any thoughts about why the unmet needs measures were not risk adjusted, that would be helpful as well. But any other committee members? Questions? Okay. Colleen, if you'd like to respond, go ahead.
Yes, so these 6 measures are a little bit more complicated than some of the ones we've discussed previously. The importance of them is tremendous, right? So we're trying to evaluate for the 5 unmet needs measure and the physical safety measure, if the participant is doing okay. Are they receiving a service that meets their needs? And so I understand many of the comments that you've raised about if the maximum number of hours that the participant receives doesn't accommodate sufficient support for toileting, it can be difficult to say, well, at 3 a.m. I don't have support to use the bathroom. And so obviously making sure there's a plan in place is critical for the personal care assistant or behavioral health staff member to address. But there's a valid point there that the perception of what help means can be interpreted differently depending on the individual who's responding. That said, when this experience of care survey was originally developed back in 2016, the expert panel that provided influence into how the questions were shaped, as well as the advocates and the consumers from whom we heard, including 20 interviews, a focus group, a number of ways that we collected data from participants, they underscored the importance of these questions because an unmet need should be addressed. Whether it is that question about toileting at 3 a.m, there needs to be a plan. And so it's hard for us to balance the difficulty in the quantitative assessment that was presented versus the value add that the community receives from these. For the risk adjustment strategy, these measures are difficult because we have a denominator for one of 30 and a denominator for the other of 2,625. And so it's almost impossible to case mix adjust the measures as they're currently, based on the data that we had. For the measures for which we have a larger sample size, it's possible that we could consider risk adjustment in the future, or excuse me, case mix adjustment in the future. Risk adjustment, again, is not feasible because these are single item measures. And so the schema that we've developed for risk adjustment that is used by other CAPS developers, so we use a similar strategy for that's used for other CAPS instruments, it doesn't fit with the way that these measures exist. And so we're trying to balance here the results that we're presenting with the tremendous feedback that we've heard from the HCBS community about the value add that having these data gives to the Medicaid office or the managed care plan to ensure that they're addressing the problem that's being identified. And then for the physical safety measure, just one final point, we have almost no data because no one's getting hit or hurt, which is great, but it just makes analysis difficult.
Thank you, Colleen. And Aaron, thank you for dropping that question into the chat. So for those, you can see how the help is defined here, what that means. And as Colleen had mentioned, it's a single item. So that's the rationale also for these unmet measures, why they're not risk adjusted as well. I'm going to circle back, Stefan, Carol, Sarah, any additional follow-up with that? Again, it's based on what Aaron also dropped into the chat. But Stefan, you got your hand raised. Not sure if it's a follow-up or you have additional comment. Nope, okay. Carol or Sarah, anything you wanted to add or circle back on?
No, thank you. That was great discussion.
Okay. Yeah, okay, green, Carol. All right, thank you. Almost through this stretch here, so I just will do a last call on what we're looking at are these 5 unmet needs measures. Morris has pointed attention to those last 3, 4, and 5. So I think we'll be voting on those separately. But then also this hit or hurt measure, which had some no reliability issues, but also just noting that no major issues with people getting hit or hurt. So that's good to hear. Last call for any questions about these measures. Aaron, yes.
Yeah, I was just pulling up the survey tool to look at all the questions, and it looks like there are a handful of questions for each one of these topics. Are those responses consolidated in some sort of way when scored, or is it purely looking at the one specific question around dressing, bathing, and separate one question around toileting help? Does that make sense? So it
does,
yes.
Yes.
It seems like there are multiple questions in the same category here, but not sure on how it's scored.
Yeah, so they're feeder questions, right? So the question that was dropped into the chat as an example related to toileting helps an individual fall into the question that's used in our measure. And so you can, if you scroll up a little bit in the chat, I did drop the questions for the unmet needs measures into the chat. So they basically are in the last 3 months. Did you have a lack of a service? So that's what we're measuring, right? So you can get into the measure if you say, I did not have the assistance with toileting. And then the question itself for the measure says, is it because your staff member wasn't there? So we're explaining what toileting means, what the household tasks, what medication support, what food support means. We're already narrowing it down pretty close because we're saying the person already said no, that they did not have the service that they needed. And so that's why our numbers are so low. This single question is what's used in the measure, and then we only have the individuals for whom an unmet need was identified. So we're not saying out of the whole population who has an unmet need, it's did you fall in because you didn't have an unmet need? And then we ask, is it because you didn't have a homemaker there to help you with household tasks?
Okay. Aaron, any follow-up with that?
No, thank you.
Thank you. Okay. All right, anyone else? Okay, let's go to a vote. So again, for the first 2 on unmet needs and the hit or hurt, not hearing any comments from the committee on that. So when you're voting on this, you're considering those 3 measures, right? So first 2 unmet need measures and that hit or hurt, and we could open up the vote for that. The conditions still would apply to those 3 measures. And for the others, we will, that Morris is drawing attention to, we'll vote on those separately here quickly.
with us as we wait for the questions to show up. Voting is now open for measure 2967 on the unmet need in dressing and bathing due to lack of help. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. And we are expecting 12 votes. We lost quorum, so at the end of the vote, I will not be sharing the voting results. We have all 12 votes in.
Okay, just confirming that again, I think it looks like we have lost some folks that stepped away. So just to confirm, if you are still on the phone and not voted, please do so. Okay. So with that, let's go ahead and move on to the third unmet needs measure. So again, the condition can be placed on this measure, but the concerns here were that the reliability for this was an issue that was brought to the attention by the committee for this third unmet needs measure. So let's open that up for vote.
Voting is now open for measure 2967 on the third unmet need measure. Unmet need in medication administration due to lack of help. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. We're waiting for one more vote. We have all 12 votes.
Okay, we'll go to the next unmet needs. This is the measure that had about 70% of entities below 0.6.
Voting is now open for measure 2967 on the fourth unmet need measure. Unmet need in toileting due to lack of help. Based on the evaluation of this measure, please indicate your endorsement decision. Vote for endorse, endorse with conditions, or removal of endorsement. Waiting for one more vote. We have all 12 votes in.
Thank you. And we'll go to the last unmet needs measure. So this one had, again, about 60% of entities below 0.6.
Voting is now open for measure 2967 on the fifth unmet need measure. Unmet need with household tasks due to lack of help. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, or removal of endorsement. Waiting for one more vote. We're waiting for that one additional vote.
At this point, Isaac, who's that?
It's Jeanette.
Jeanette, are you having any difficulty?
Sorry, I'm logging it as we speak.
Thank you.
Thank you. Okay, so I do, since we aren't able to display the votes, so Jeanette, go ahead and submit your votes. Unfortunately, some members had stepped away, so we won't be able to display those votes on those last measures, but we will follow up with them and collect those offline. So we have one last measure. So thank you all very much for sticking with this. This last measure, it didn't have a lot of that to go through. Again, as we approach these CAPS-like measures, it'll be very different as we move forward. So thank you for your attention to go through all of those discussions here. I do want to just pause before we're going into this to see if anybody wants to take a brief bio break or walk away for about 5 minutes. So yes. So if you could please just come back for this last measure, that would be great. So let's come back. We'll give it at 4:10 and we can conclude our discussions for today. Thank you. Okay. About 10 after the hour. Almost there. Now it is. All right. I know this has been a very long day, everyone, so thank you all very much for your time and attention to this. We do have just this one last measure to do before we adjourn today. So we just wanted to bring that to everyone's attention. And Colleen and Lewin Group are here as the developer representatives for that measure as well. All right. Just give a few more seconds here. Okay. All right, great. So let us go through this and see if we can get through this. There's only a fewer items listed for discussion on this one. So this is CBE number 3453, continuity of care for inpatient or residential treatment of substance use disorder. You can see the description here, percentage of discharges from inpatient or residential treatment for substance use disorder for Medicaid beneficiaries ages 18 to 64, which were followed by treatment services for the substance use disorder. So that type of treatment services include having an outpatient visit, intensive care outpatient encounter, or a partial hospitalizations, telehealth encounter, filling a prescription or being administered or dispense of medication for substance use disorder. There are two rates that are reported: continuity within 7 and 14 days after discharge. I mentioned the developer and steward, and this is a maintenance measure. It's the current planned use is quality improvement with benchmarking, as well as quality improvement specific internal with the organization. The process measure, you can see the target population 18 to 64 with substance use disorder treatment, very specific care settings here, and the population or geographic area being the state. So Colleen, any opening remarks for the committee's consideration?
Yes, hello again. I'm not going to introduce myself again because I've been speaking for the last 2 hours with you. So you know who I am. I'm Colleen McKernan from the Lewin Group. I'm joined today again by CMS, as well as representatives from the Substance Abuse and Mental Health Services Administration, so CMS and SAMHSA. The original testing work for this measure was conducted by Mathematica Policy Research, and the maintenance efforts for this measure were transitioned to our team in September of 2019. So CMS developed CBE 3453 for use in state Medicaid programs with an aim of monitoring care coordination for participants recently treated for substance use disorder, or SUD, diagnoses. Initiation of follow-up care after discharge from an inpatient or intensive outpatient setting manages participants' symptoms more effectively and improves their overall function. Data from the literature suggests that participants with SUD who have at least 2 encounters during the 6 months following discharge reduce their risk of relapse substantially. CBE 3453 evaluates the first step in this process, measuring the completion of at least 1 visit within 7 or 14 days following discharge. It is one of 3 measures in a suite stewarded by CMS that assesses care for participants diagnosed with substance use disorders. CBE 3312, continuity of care after medically managed withdrawal from alcohol and/or drugs, maintains its endorsement by the consensus-based entity following review in spring of 2022. And CBE 3400, pharmacotherapy for opioid use disorder, was re-endorsed on Monday by the initial recognition recommendations group. What a mouthful. Beneficiaries aged 18 years and older for whom an SUD is diagnosed and with a discharge documented in the Medicaid or Medicare data are eligible for inclusion in the denominator for CBE 3453. Encounters that occur in a year for which participants are placed on hospice, those that happen after December 15th of the measurement year, or for whom a direct transfer to another inpatient or another residential treatment location are excluded from the measure. Then, among those in the denominator, individuals are captured in the numerator if they have an outpatient visit, intensive outpatient encounter, or partial hospitalization with a primary or secondary diagnosis of SUD on the day of discharge through day 7 or day 14. They also are included in the numerator if they participate in a telehealth encounter for SUD on the day after discharge through day 7 or 14. If they fill a prescription or administer or dispense a medication on the day of discharge through day 7 or 14, or are admitted to a residential treatment facility on day 3 through day 7 or 14. And that's for inpatient discharges only. Since the measure's development, we have expanded the population that's eligible for inclusion in the denominator. So there was actually already a note about this in the chat, but we added older adults. So those age 65 years and older are now included in the measure, as are beneficiaries who are duly enrolled in Medicare and Medicaid. Engagement in continuing care after intensive treatment is an important goal, but it is difficult to achieve. Using 2021 Medicaid and Medicare claims data, Lewin identified substantial opportunities for improvement at the state level. Performance scores vary from 9.7% to 54.8% for follow-up within 7 days, and then from 14.1% through 62.2% for follow-up in 14 days or fewer. That includes that 7-day range. This substantial variation in state performance scores suggests broader national use and increased communication about this measure could reduce variation both within and across states. Improvement in performance is especially important for subpopulations that we capture in the denominator, including those new ones that we added, such as older adults and those who are covered by both Medicare and Medicaid. So just a final note, late last year, CMS entered into an agreement with SAMHSA to transition stewardship of this measure. Collection and reporting of performance information will provide states and relevant stakeholders with a method to evaluate how care is provided and accessed over time. SAMHSA is working to improve engagement with and use of CB 3453 to support its goals to reduce SUD diagnoses nationally. And so again, look forward to our discussion today, and I'm here to answer any questions you might have. Thank you.
Thank you so much, Colleen. I appreciate that. So let's go ahead and move to our discussion point slide here. We just had one related to this that we had identified, but definitely there could be others the committee members proposed. So use and usability here, it's just the current use of the measure is documented. The feedback was sort of inconclusive and additional data may be needed. And the developer did provide some inputs on this in their measure submission. Really that it's not had any interaction with states who have been using this measure. The data are blinded, and so public data that could be compared. There's not any public data at this point. And then neither CMS nor Lewin have received any feedback, positive or negative, about the feasibility and use of this measure. And the developer obviously can consider potentially reaching out to a couple states as well. So let me open it up to anything from Stefan or other patient partners before going to the committee.
Is anybody else game? I guess I'll lead off then. So to start, I'm not really sure, again, because I didn't dig deeply enough into the details. How long has this particular measure been in effect for as a measure?
So about 6 years. The original development happened before our contract took over. We took over in September 2019, and it was relatively nascent then. I will note that CMS is on the Medicaid side, especially previously, it's changing a little bit now, but puts out measures for optional use by states. And so they're available, the technical specifications are posted. The state can use it if they decide that it's in its best interest for quality improvement. With the transition of stewardship from CMS to SAMHSA, we anticipate that there'll be additional opportunities for use, potentially more structured use than just optional specifications being available. And so this transition happened recently. We've been partnering with CMS and SAMHSA to make to get everybody on the same page and make this submission work. And so I expect there to be additional use data in the future, again, because of the transition over to SAMHSA.
And Colleen, do you know if there are, I shouldn't say it that way. So Colleen, you did mention that there are a number of related type measures within the overall fold. So I don't want to pursue this just related to this particular measure, but I'm realizing that the data that's presented does tend to skew towards older adults, and I can appreciate that. Let me get back to my notes to make sure. I am just guessing that perhaps those people that are coming out of some sort of a treatment plan or inpatient program would tend to be older. Is that a fair generalization?
So actually, the opportunity for improvement is greater in the older population, but we see the performance gap exist for all ages. So our distribution of performance shows an opportunity for improvement for younger adults, middle-aged, and older. The older population that we just added to our technical specifications, so those over 65 and those on Medicare and Medicaid, the gap is far larger. And so that actually shows that even though the measure has only been available optionally to states, the influence of the guidance in the measure has demonstrated improvement over time in the under 65 population. And we hope that, again, broader use of the measure would increase continuity of care for everyone, but especially for the older adults who are disproportionately affected.
But typically the documentation is gathered in the same way, regardless of age, same facilities. Okay.
Correct.
Yeah. Yep. And Stefan, any thoughts on like how this might be valuable to the patient community? Do you think this is an important area of measurement?
Well, I do. And again, I just wanted to make sure that I wasn't going to speak out of turn. As I looked at this, I thought to myself, okay, let's just go and hear what's there. But, you know, I do have some connection with people that work with patients that are SUD. And probably the most tangible and palatable one for myself is I had the opportunity to meet someone 2.5 years ago who actually started a new nonprofit in our area. And it was based on her son's experience. And her son had addiction problems, and he found that the best way to keep him sober, clean, straight, whatever, was peer support. And I don't know if the data set can drill down to find out what types of post treatment plans are most effective. But from what I understand, programs that involve peer support for people that are in the 18 to 24 year age bracket is very effective. Now, I'm not going to, begrudge the older people their due, because I fit in that category. But if you work with a population that's younger, maybe you don't have so many that are older. So could you tell me where that idea fits within the research and the understanding of the problem as you see it?
Here, go ahead, Colleen. You wanted to address that?
Yes, thank you so much. So the types of follow-up care that we can capture within the numerator of this measure are limited to those services that are billable to Medicare or Medicaid. And so if there is a peer support component within a residential treatment setting, so we have that arm, if you're in an inpatient setting, you get discharged and then you go into a less intensive residential setting, there is peer support provided there, regardless of the age of the individual. If there's peer support in the community, so building a community inclusion for the individuals who are captured in our denominator, that's not something that we would necessarily be able to capture. And so the only things that I can measure are things for which there is an administrative claim documented because there's a billed service. That said, this is definitely a topic that I want to bring back to my technical expert panel to gather additional input and also just explore the ontology of the codes that are being used to make sure that we're covering, to the extent possible, all of the types of services that Medicaid and Medicare pay for that fall under this umbrella.
And would you happen to know if there is a code that would be dedicated to facilities that are specifically peer support?
So we don't look at we don't use place of service codes to identify the care. We use CPT codes. So it bills for the type of service that's provided. And it also, Aaron, the comment about social worker. So we don't document the provider type, but I'm going to pull up our value sets and I'm going to do a quick search to see if there's any sort of granularity within our value sets to differentiate those two items.
Okay.
Thank you, Colleen. Yeah, and I also, and Stefan, I just also want to draw attention to that. Carrie also mentioned she had no other additions or comments here from a patient perspective. I'm not sure if Cher had any thoughts here on this, but if not, Stefan, I didn't mean to cut you off there. I just wanted to make sure that we recognize Carrie's comment as well.
No, that's fine. That's great.
Okay, thank you. And thanks. And so I also draw attention to Aaron dropped in something into the chat about why not include less than 18 years of age. Colleen had mentioned it's a great suggestion for future consideration updates. But Aaron, any follow-up on that from you? And if not, okay.
No follow-up, just recognizing that there's an opportunity there to meet that population's needs as well.
Thank you so much. And Cher, thanks for also saying no comment on this measure. That's great. And then a colleague just saying that they use ICD-10 PCS codes, which capture interpersonal care. Okay. Paul, you have your hand raised. Go right ahead.
Yeah, thank you. I was just kind of curious about that last bullet point and a strategy moving forward. Would that be sort of a census-based region look, or would you look at more of the prevalence of where some of your data are this versus that?
So I think both options are,
thank
you. I think both options are available to us. Certainly for states that are using this measure that have opted in to optional use, we want to be proactive and prospectively gather those data. This is a comment that we received like 3 weeks ago, so we haven't had a chance to do it yet, but it is on the to-do list for us to make sure that we're gathering those qualitative data. And then we do have partnerships across the country with different Medicaid offices with which we've worked for other measures, like our last conversation for HCBS caps. And so we have individuals from whom we could solicit input in addition to those states that are currently using the measure. So both.
Thanks, Colleen. And Sarah, your hand's raised, and I'll go to Aaron. So Sarah?
Thank you. I do have a question that builds in concept from Stefan's. In terms of what's concluded in the numerator, in terms of continuity of care, can you just speak to how pharmacotherapy and that build service of filling a prescription, how does that compare? Or I guess I have difficulties in seeing that as comparable to an outpatient or telehealth visit or admission to residential. So how, in terms of quality of continuity care, how those are how are those all lumped together?
Sure.
Thanks, Sarah. And sorry, Colleen. Maybe I should just go to Aaron. Sorry, just before I go to Aaron, you put your hand up and put it down. I didn't know if you had a follow-up question.
Yeah, no, I was just going to ask the exact same question as Sarah. I didn't understand how prescribing a medication on the day of discharge related to continuity of care. So thank you for that, Sarah.
Great. Thank you. Thank you, Aaron. And Sarah, any others on the committee have additional questions? Again, thinking about, is this something that's really going to determine your endorsement decision here as well? But anything from the committee, either this topic or others? Morris, go ahead.
Matt, this is more of a logistical question for you, but my understanding is this is technically two measures. There's a 7-day measure and then a 14-day measure. Are we going to be voting on these separately or together?
This was submitted as one, so we're just voting one time. But Colleen, maybe you can also speak to the 7 versus the 14-day. Thank you, Morris. So we can get some clarification there too. And then Carol.
I want to get some clarification. So the entity being measured is the state or geographic area. This doesn't, because it's blinded, it can't track back to say, okay, discharges from this particular setting or entity to actually see if there's a difference in what's happening or what potentially is happening at an inpatient level that might be improving things at an outpatient level. It's just a picture of what's happening in the state. Is that right?
Okay, just some clarification on what we're looking at within the state versus something else there. I'll capture that. And other comments or questions on any of these topics? or it's something new? Okay. Colleen, so we heard a lot about what Sarah and Aaron were asking related to what's included in the numerator, thinking about how does filling a prescription compare with outpatient telehealth. Morris asked about the 7 versus 14 day, and Carol, her last comment about the state entity and what we're looking at here, wherever you'd like to start.
Sure. So to start with medication management, medication-assisted treatment, or MAT, is the gold standard for opioid use disorder, which is a large portion of the individuals whom we capture in this measure, and MAT is applicable to other populations as well. And so MAT is most effective when it's done in a you get more than one bite from the apple. So use of MAT in combination with talk therapy, potentially intensive outpatient or short-term admission, is often the best care for the individual, but not everyone wants every type of care. And so the measure allows for multiple different treatment paths to insert the participant's preference into the measure. They can work with their clinician to identify the most appropriate treatment immediately following that discharge. And then, as I noted, this measure is the first step in creating continuity of care over time. And so we don't measure it in our measure. That would be a different evaluation, but looking at additional encounters down the road, either more medication dispensation or counseling, or the various types of talk therapy we include. So that is one. The 7 versus 14. So we don't consider it two measures. We just report two rates. The 14 rate is subsumed within the 7-day rate. And so really we're just providing the two data points for states to say, okay, so 7 days is, ideal. So an individual doesn't fall out of care. They're captured within a week. Something happens. But not everyone hits that 7 days because of availability of providers and a bunch of reasons that are logistically outside the control of CMS and the state. And so we also want them to have the data that show, in addition to 7 days, how many individuals are captured in that 8 to 14 day range. And then discharges. So the data are currently blinded for the package we've submitted, but CMS and SAMHSA have the unblinded data, and our state partnerships and conversations that we have with individuals could provide unblinded data. And so the participants, should states calculate the measure or we work with them to calculate it, can trace back the varying experiences of their participants. We just don't report it here because a decision has been made to blind the data that we present.
Great, thank you so much, Colleen. Carol, your hand's still raised. I don't know if you had a follow-up, but I also draw attention to what Aaron has dropped in the chat. Just curious how relapse is accounted for when looking at the numerator criteria. Should this be an exclusion of some sort? Question mark there. And maybe Stefan, did you have a follow-up based on any Colleen's comments or something new?
It's a little different, so I'll let.
No, please go ahead. We'll capture that and we can keep moving.
So I want to understand the logic model for this whole situation. So if someone is discharged from an intensive or inpatient therapy program for substance abuse, the hope is that the community resources will be able to support that person. This is a measure of those people that come back in for some sort of intensive or residential treatment. Is that correct? Oops, lost you.
I could not unmute. So no, so there is the option for an individual who is inpatient only to go into the community for a couple of days. And then on day 3 or later, they could be admitted to a residential treatment facility. And so we are saying that not everyone's care can be managed in the community. And so maybe they go into a residential treatment facility, it's a step down from an inpatient, and then they may fall into the measure again when they have an additional type of treatment that's provided in the community at a future date. There are options for treatment that can be managed entirely in the community, such as telemedicine, or the dispensation of medications that could occur on the day that they're discharged or in the 14 days when they're in the community. So there are ways for an individual to go access community supports within those 7 or 14 days and return to the community.
So it's either data points where people access community-based health for substance abuse.
Exactly.
Okay. Then I think that clarifies things for me as far as additional questions. Thank you.
Thank you, Stefan. So I wanted to see if wanted to circle back on Aaron's question as well in the chat, Colleen. And it looks like Morris is talking a little bit more about use and usability. I'm happy to hear from you, Colleen, that SAMHSA is now involved, as I suspect that they will be well equipped towards improving continuity through the existing CCS TAT program. So just a commentary there. Thanks, Morris. So maybe we can circle back on Aaron's question, Colleen.
Yes. Yes, so at this time, we don't capture relapse as an exclusion. So we want to show what happens in the community in that 7 to 14 days. Interesting point that you've raised, and definitely something at which we would want to look at some sort of sensitivity analysis to say, okay, an individual within that 14 days, do they end up going back to the same type of treatment or higher intensive treatment than what they're capturing in the step-down residential treatment or in the outpatient care? And so not something that we have addressed to date, but it is something that I'm writing down and we will talk about with CMS and SAMHSA.
And just to clarify, I think my concern was that a patient that relapses and has some sort of treatment is inadvertently meeting the numerator as if it's a positive thing, when in fact it shouldn't be bucketed the same way as meeting the numerator. That makes sense.
Yeah, so you're saying like they get a medication on day 1, but in day 7 they need to go into inpatient, something like that. Yeah, right. Something that we have not explored, but it is something that we will. So thank you for that.
And then my other last point, just to circle back on my first comment about the prescriptions. Absolutely hear your comment about, you know, it's usually a prescription in combination with something else. Fully understand that. I think my concern still resides in meeting the numerator based on a prescription that's given at the time of discharge. If it was something that was prescribed or a refill down the road, that would make sense. But giving it at the time of discharge, I don't see how that meets the continuity of care intention of the measure.
Thanks, Erin.
So if I may clarify,
ahead,
Matt, so it's medication dispensed on the day of discharge. And so how I interpret that is that they are discharged and they immediately are given the medication. But I understand that there could be some conflation between, okay, here you go, please leave, here's your script, and then nothing happens. And so it's something for us to look into. We don't want to have that unintended consequence. So appreciate that feedback, Erin.
Thank you, Erin. Stefan, you still have your hand raised. Not sure if that was a leftover as well, but I do know, Morris, you have your hand raised. Thanks, Stefan. So go ahead, Morris.
Yeah, just building off of what Erin just said, which I think is an interesting, valid point. Is there a way that you could just add a third rate, Colleen, that would have a one-day measure to kind of address this specific concern so that people could, disentangle the sort of dispensation at discharge versus more of a follow-up?
Go ahead, Colleen. Do you have any thoughts on that?
Yeah, something for us to explore. I cannot speak specifically to the literature that looks at 24 or 48 hours following discharge and how care is managed. I'm sure there are publications, and I'm also sure that those data would be meaningful, but I'd want to talk to CMS and SAMHSA to think about it. All of these things, every single suggestion that's been made so far is tremendous. I can't say all of them will work, but they're all things that we will explore to see if they would fit into the measure.
Thank you. Thank you. So, Erin and others, Morris, others who have been asking questions about this, are anything that's been discussed or raised that is questioning your endorsement of the measure? Any of these areas that's being discussed, especially hearing that the developer will explore these, but that being a question for you.
I would consider the question that Erin raised to be a condition for exploration. Erin, it was your question, so I'll let you own it, but it feels like it to me.
I do have some concerns about what is qualifying for the numerator. I think that there's just a little bit too much cloudiness there in terms of, a potential person who's relapsed versus actually receiving follow-up care. Also the concern about pharmacology meeting the numerator. And then someone else has raised the issue of the window of follow-up, 7 and 14 days. That is extremely narrow when we're talking about substance use disorders. So, and again, the intent of this measure is about continuity of care and helping patients long term. 7 to 14 days is not long term, especially given this condition. So I have some real concerns about the efficacy and value of the measure as it is today.
Okay. And so if there would be a condition on this, Aaron or Morris, or maybe others who have similar thoughts, could you elaborate on what maybe that would look like for you? Maybe Aaron, any initial thoughts?
I think addressing those points that I just called out, retweaking the measure, I think would add significant value.
Okay. So I see Carol, your hand's raised, and then Sarah, and then Stefan. So Carol.
Yeah, I think what we're talking about goes to the issue of usability as well, because I'm struggling with the answer that I got from Colleen, that this is at a state level. I mean, if part of this is to help identify what's happening inpatient that seems to be having an impact on outpatient or follow-up, that would be helpful. But if like I said, if somebody has a relapse and we don't capture that, or they're getting a prescription filled on the day of discharge and nothing else happens, I don't see how that contributes to the usability of this measure in terms of who gets the data or who gets the report and what they're doing with it. And it just seems like addressing some of these other issues, if a state can break it down and say we can break it down by where they're being discharged from or whatever, it starts creating a pathway to what are the practices that need to change or be improved in order to get to do better. And right now I'm just not seeing that, considering that the issue of use and usability is kind of, I think those link to the issues that Aaron and Morris were just describing.
Thank you, Carol. Sarah, and then Stefan.
I think my concern lies with medications being part of the safe discharge process, which is distinct in my mind from the continuity of care provided with a follow-up visit. So that would be where my concern lies for this measure.
And then Stefan.
So, as I thought about my concerns about this measure, I also concluded that it's a matter of usability. A facility, the facilities don't really have much input about what's happened in the 7 or 14 days since the initial discharge. And, I completely agree with Aaron, and that window of time is entirely too small. And without going into details, I understand more than perhaps I would disclose about the pattern of users. And so the users get no benefit really, because the facilities don't really know what they did or didn't do that was helpful. And for the facilities who are truly interested in improving their standard of care, they don't really have much to go on, because it's just, did you come in? Did we treat you in whatever fashion that facility uses to treat people in their situation? And so the facilities don't really get any bang for the buck on this either. So there you go.
Great, thank you, Stefan. And so, thank you, Morris, for kind of asking Aaron to lay out her concerns here in the chat. But Colleen, I know we've been kind of touching on some of this, but do you have any responses to some of these concerns here from the committee, especially thinking about this at the state level, with the use and usability concerns, and anything else you wanted to add about some of the numerator items that were discussed?
Absolutely. And so totally agree with many of the things that were mentioned. I think that some of the long-term care issues are addressing a different problem than we're trying to measure. And so the reason why we evaluate 7 and 14 days following discharge from an inpatient facility or a intensive outpatient visit, et cetera, is because loss to follow-up can happen extremely quickly after the individual leaves setting of care where they're monitored closely. And so the 7 and 14 days provides an indicator to the states at how effective it is when a person returns to the community that they become engaged in a treatment plan. And so acknowledge totally that treatment for substance use disorder is not linear. And so there can be times when an individual requires additional support and may need to step up or step down in treatment. The feedback about the medication is well taken. It is included in this measure because we wanted to ensure that the participant preference was acknowledged. And so many individuals find that MAT is the primary intervention that can help manage their substance use disorder in the community. As I noted previously, MAT in combination with other therapies is the gold standard, but it is not for everyone. And so want to make sure that there are options for individuals to access the type of treatment that is of their preference. That said, I think it is important for us to explore penetration of these various points into the 7 and 14-day window. So looking at 1 day, looking at 2 days, as you suggested, Morris, looking at what a combination of medication-assisted treatment with a refill, since many pharmacies will only give you a week's worth of medication at a time. So looking at what a refill requirement would look like versus a dispensation on the first day. Also in combination with some sort of intervention that is group therapy, some sort of behavioral intervention. And then finally, the point about the level of accountability. So we see this as an indicator measure that states can use to help to work to improve the community inclusion and experience of individuals on the ground. And so a measure like this would be tremendously difficult to attribute if it were at a facility level, because there's multiple interventions that we're trying to measure here, right? So we're not saying that the inpatient facility from which the individual is discharged holds all of the accountability that they access care. It's also the community inclusions that I mentioned previously. It's an interdependent network through which individuals access the various forms of behavioral and pharmacotherapy intervention. So we want to make sure that at a state level, we can measure all of that, anything that's billed, and so that we're documenting the various options that are available to individuals at a state level, capturing the whole story of the individual.
Thank you. Thank you so much. And Morris, you do have your hand raised. I wanted to see if there's any other additional topics. We've been talking about some of these concerns, and thank you, Colleen, very much for addressing those. Before maybe trying to summarize and see if we can move to voting here. But Morris, go right ahead.
Yeah, I just want to make one comment in regards to the relapse, and this might not be a perfectly apt metaphor, but for me, whether or not the patient relapsed seems almost orthogonal to whether or not the patient got follow-up care. Kind of putting it into a metaphor that makes sense to me in the world that I typically operate in. If you give a patient a flu shot, it doesn't necessarily mean that you should be dinged because the patient got flu. Obviously, that's not a perfect metaphor, but it feels to me like we would be measuring two different things if we included relapse in the measure, and I don't really think that's appropriate in this case. There's probably people who can say this better, and psychiatrists who actually understand sort of, does having the follow-up care mitigate the possibility for prolonged relapse? Maybe you're actually, even though that person relapsed today, maybe they're less likely to relapse, 5 weeks from now. I don't know anything about that, so I can't speak to it, but I feel like there's value in the follow-up regardless of the outcome.
Thank you, Morris. Aaron, you have your hand raised. Not sure if you wanted to add to what Morris was saying.
Yeah, I just wanted to respond to that, Morris, just to clarify. So when I was raising the issue of relapse, I feel like my point was to exclude those patients from meeting the numerator. You don't want to give credit for having a patient come back due to relapse. I think it makes sense to exclude them from the population so that they're not dinging the clinician or getting, artificial benefit from the patient relapsing, right? They shouldn't be considered in the measure at all. Does that make sense?
It does make sense, and I did need the clarification. I could probably still argue that the fact that they're coming back might be beneficial, but I feel like that's a clinical argument, and I'm not equipped to make that argument.
Yeah, same boat. Thanks.
Go ahead, Aaron. Thanks, Aaron. And then Carol, you wanted to weigh in on that?
Yeah, I just think given the explanation Colleen gave of how this measure is being used, I think Morris's example of like flu shots applies, because if it's really out there to help the state understand what's going on, I don't think the issue of whether somebody relapses or not matters for the kind of information this measure actually provides to the states.
Thank you. So hearing maybe a lot of this question around the usability here and what's it providing. So maybe we could propose that the developer do an exploration of the demonstration of that type of usability, so how states can use the measure to improve patient experience of continuity. So I think maybe that starts to touch on some of these other issues that we've been hearing as well. But would that be something feasible, Colleen? Would you consider? Yes. Okay.
Yes, absolutely. All the feedback we've received are things that CMS and SAMHSA have heard and that will be brought back. I can't say all of them are possible to accomplish, but every one of them will be discussed and evaluated.
Okay. Great, thank you. So I want to try to move us to a vote here. So I want to just look at Kristen and Stefan. With this condition I mentioned about this exploration of that demonstration of usability. So again, how states can use the measure to improve patient experience of continuity. So when that measure does come back for maintenance, there will be some description of that exploration, getting into some of these issues that we've been talking about. Stefan, Kristen, anything we may have missed there?
My only concern is, does that condition as worded by you right now, does that address the concern about the medications? I keep hearing that the medication prescription, how you worded that condition, and doesn't seem to take that into consideration, I don't think, and that is what I keep hearing as being a big issue.
Okay. Yeah, so I think we're
so it's kind of, it's more, can it be more, can the condition be a little more generic in terms of reviewing the numerator criteria with those, paying attention to those specific, it's really the numerator criteria is what I keep hearing from as I'm listening. Does anybody disagree with my summary on that?
No, I think that's right, Kristen. That's what I'm hearing, that we should look at the 4 topics that Aaron brought up: the dispensation of discharge, the possibility of relapse in the numerator, for people coming back and getting follow-up care because they had a relapse. The window is 14, too short, too long, and then the 4th one being the age restriction.
Thank you.
So thank you, Kristen. And Stefan, I'll go to you, and then Colleen, I want to circle back with you to see if there's some feasibility questions you have here, concerns related to what the committee is proposing here as well. But Stefan?
Thanks. So I started out my conversation by saying that I really believe in community-based approaches to continuing support of people with substance abuse. I'm a little conflicted by what I'm hearing in terms of the discussion here. On one hand, we've had some people suggesting that people that relapse should be excluded from the numerator. On the other hand, if we're going to exclude them or include them, this measure does nothing to help states or facilities who originally, well, let's just say states or facilities, understand what obstacles the people with substance abuse had when they were discharged. And obviously, clinicians and, people that study substance abuse certainly have mountains of data to support that. But what we're talking about is a measure that's designed to take a look at individuals on a case by cases and then aggregate that and try and form some opinions. And that data is simply not gathered through this measure. So I'm having a hard time seeing usability, both for states and for clinicians and for patients. And I appreciate that we want to do some sort of follow-up. It's a noble effort, but I'm having a hard time seeing the usability at this point for those reasons.
And thank you, Stefan. I think what I'm hearing here is there's this exploration of some of these numerator concerns, the follow-up window, how relapse was accounted for in the numerator criteria, having the pharmacology prescription at the time of discharge, and also this prefer the age restriction less than 18. So I think just the exploration there, and to your point, Stefan, sort of this exploration around, you know, the usability aspect with the accountable entity and state, and thinking about you know, how states are sort of using this to help improve that patient experience, maybe getting a little bit to some of the thoughts that you were just alluding to here around how it's useful to the entities or facilities and patients. So sort of expanding that kind of condition to capture those numerator concerns, again, just exploring this from the developer as well, maybe with their technical expert panel, but also this usability element. But I want to move us to try to see if we can get to a vote here. But Colleen, any of that raise any sort of flags for you, or does that seem to be feasible for you and your team?
So for the 5 items, defining relapse and evaluating its impact on both the inclusion in the initial population and the impact on the numerator, evaluating the interaction of pharmacotherapy with behavioral interventions, and if it should be in the numerator at all, or how we measure it, including day of dispensation on the day of discharge. The look forward window for 7-14 days, and inclusion or stratification or something for individuals under 18, all are accessible using administrative claims, and I have no concerns about the ability for us to do that. For the usability item, Stefan, I think it's tremendously important for us to address that. We do see this as a surveillance measure, and so not something that necessarily would be used by an individual person, but rather at a macro scale at the state level. That said, I think it's very important for us to gather those usability data to make sure that we're addressing the concerns that you summarized. So I plan to take the notes that my coworker has taken and make sure that all of that is documented and assessed qualitatively as well. So all 5 of those things are things that we will address.
Thank you, Colleen. And Morris, hand raised? Yes, maybe.
Yeah, I want to make this quick. I know we're short on time. Colleen, if you could address Stefan's concern in a more augmented logic model, I think that would help a lot to just kind of show the mechanisms for how you think this surveillance measure will actually be implemented to improve quality.
Absolutely.
So, and also reevaluating the logic model to address Stefan's concern. Thank you. Okay. So I want to summarize here. You know, we're looking at those elements with the numerator. So as Colleen had summarized, but potential updates to numerator criteria to include that follow-up window, impact of relapsed patients less than 18 years of age, and pharmacology prescription at the time of discharge, as well as a demonstration of this usability with the accountable entity at the state level, thinking about how they're actually using this to improve patient experience of continuity, and then exploring the expansion of that potential logic model to include some of what Stefan was mentioning as well. Okay. Great discussion on this. Let's move to a vote. So that will be the condition that we're placing here. So that'll be open for you. And Isaac, I'll turn it to you for our last measure to vote on today.
Voting is now open for measure 3453, continuity of care after inpatient or residential treatment for a substance use disorder. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, or remove endorsement. We're waiting for one more vote. We have all 11 votes. We can move forward.
Great, thank you. And apologies again for losing quorum. Colleen, a big thank you to you and your team for addressing all of these questions from the committee today and going through all of that. I know that was a lot, so thank you for that and considering all these conditions. So thank you, Colleen. Also to the committee, thank you for hanging on. I know this was a long day and we got through a lot of information. Again, the approach to these CAPS-like measures will be very, very different moving forward, not what we experienced today. So please, thank you very much for your flexibility and your patience. And with that, we don't have time for additional measure discussions. So I'm going to just say, if we go to the next steps briefly there, Isaac.
We'll be publishing a meeting summary on August 30th containing endorsement decisions and rationales. And that will start the 3-week appeals period during which any interested party may request an appeal regarding any endorsement decision. The appeals committee will be meeting on September 30th, and this meeting is open to the public. Around October, November, we will also publish the final technical report. I'll pause here to see if there are any questions. Seeing no hands raised, I'll turn it over to you, Matt, for closing remarks.
Thanks, Isaac. So we'll go to the next slide. I just wanted to thank these members on the committee today. Their terms are ending as of the end of this cycle, unless they wanted to nominate themselves for a future committee. So thank you for your participation, both for fall and spring. I really appreciate all of your time and attention, especially leading up to today as well. Also, thank you to our co-chairs, Kristen and Stefan. They will be stepping down and serving as members next year. We'll be putting new co-chairs in place going into the next 2 cycles. But let's go to the next slide. Stefan, Kristen, any final remarks before we adjourn?
No, other than thank you. And thank you and wonderful discussion. We went from like 4 measures that people had like personal experience with, so that I know that came into the conversations. And then we went to really scientific stuff. And so it was a great day. It was a lot. And thank you for all of your perspectives and insight, and enjoy the rest of your summer.
I would just second Kristen's comments. I'm not going to say anything more, but thank you. Besides, it's happy hour on the East Coast. Oh, wait. We just talked about a substance abuse.
Great. With that,
can I say
one
other thing that I forgot to say? So Morris and Aaron and Carol, thank you so much for your and everybody's insightful comments. Yours resonated a lot today. And as a nurse, I care about the patient outcomes, but as a nurse in quality, I also care that we're doing enough to support our providers in understanding their quality, and having good measures is key to that. So this discussion really contributed. So thank you. I'm happy to be part of this group. I'm grateful.
Thank you. And thank you all again. This is a long day, like I mentioned, and thank you for sticking with this. We'll be following up with those offline votes and letting you all know how that decision turned out, as well as the developer. Again, thanks to them for all of their time. With that, have a great remainder of your evening, week, and summer. Reach out with any questions. Thank you very much.